Thank you, Abby. Good morning and welcome. Why are we here at Ohio State focusing on space? We have a long history in Ohio of space research, of space activity. Mentioned Neil Armstrong and John Glenn just to kick off. But the reason we're here at this moment is that about 4 years ago, Ohio State became the academic partner in one of the prospective commercial space station platforms, that of Starlab, which, as you've seen, is a sponsor of this particular series. And you'll hear more about that from Tim Kopra, astronaut, when he speaks later. A part of the award involved the creation of a science park. And that science park is what I want to talk about, the Voyager Institute for Space Technology and Advancement. We competed for this park with some of the major space centers around the country, but a combination of Jobs Ohio, one Columbus, and the Ohio State University brought that space park to Central Ohio, and it will be developed on the north side of Ohio State's airport along Route 161 with a lease of 40 years with a couple of 10-year extensions. So I'm looking forward to the renewal of that lease. What we are doing in Vista is, as you can see here, it's a standalone space science park founded by Voyager. And while it will have access to low Earth orbit through Starlab, it is platform agnostic. Companies that come to Vista can gain access to other prospective commercial space stations and also the International Space Station while it is still up there. At the science park, there will be all of the usual services you get at a science park to allow companies to come in, set up, grow, and so on. But most importantly, from the view of access to space, we expect to have a critical mass of microgravity researchers. Putting such a group together allows people to learn from each other, to find ways to get access to space, find ways to bring other operations to bear on their particular challenge, and so on. And most importantly, from our standpoint, anybody at Vista will have access to Ohio State University and the thousands of faculty and staff and the tens of thousands of students to have internships, access to high-end research equipment, and so on. So that's what Vista is planning to do. The way that this whole structure works, as you can see, again, Vista is the state-of-the-art science park, and the Ohio State University is a Tier 1 research university attached to that. And throughout that ecosystem, what we hope to bring together is the different in-space platforms which will exist. Innovators, we have 10 companies already signed up, from student startups here at Ohio State to mid-sized companies already in existence, and several international companies, and particularly in the food science area and the development of food and agriculture in space. There is investment capital available, and within Central Ohio, we've reached out to about 10 different sources of capital for those small companies and mid-sized companies to grow. The microgravity services are what you need in order to run your experiments in microgravity, parabolic flights, suborbital launches, and the space station access, which I've talked about. There are other international space science parks that are in this group, and particularly Mitsubishi's iPark, Shonan iPark, just outside Tokyo. And Mitsubishi is a major investor in Starlab, and we are engaging them in the Vista Science Park. And of course, as I mentioned again, the support services which you get in any committed science park. So in summary, the partnership between Vista and the Ohio State University, we believe, is unique in terms of the scale of the operation on both ends, the international scale, the access to low Earth orbit, and from our standpoint, the opportunities for students and faculty to get to low Earth orbit and beyond. So thank you for listening, and we look forward to the announcement of the architect for the Vista first building, we hope in the next few weeks. And then groundbreaking and all the other parties will commence after that. Thank you very much.
Okay, next up, it is my pleasure to welcome Dr. Josh Hagan, the Faculty Director of the Human Performance Collaborative here at OSU, to share more with us about the great work that HPC does. Josh? Go ahead and get this started, please. Okay, awesome. It's all you.
Perfect. Awesome. Thank you. Thanks everybody here for joining the event today. And everybody that's online. We're really excited to have you all here. Can't wait to hear all the awesome stuff you guys are going to talk about. So also happy to be part of Starlab and putting these things together. So myself and a number of our team members here with the Human Performance Collaborative at the university. And I think the foundation of the collaborative has a lot to do with kind of why we're all here today too. So really the idea behind the HPC is how do we create really, really great multidisciplinary teams and projects to go after how do we optimize human performance? And we define performance as broadly as possible. The HPC, like our perspective is every human being on the planet or off the planet can be optimized to some degree. And it's really just understanding all of the different levers that we have to really take this model that we've got that is not dissimilar to others is the allostatic load model. So what are all of the stressors in, on, and around the body? How do we measure them? How do we understand them? And then ultimately, what are we going to do with that information? Like, how do we optimize that astronaut? But then it's all human beings. So all of the support staff that are associated with an astronaut is, I would assume, astronomical. I'm sure there's thousands of people that support you on a daily basis that need to be cognitively locked in at all times or working all hours of the day. So while a lot of our research has, really focused from, we've been at this here at the university for about a decade now, specifically in the human performance optimization space. And a lot of what we do day to day has been on, let's just say the more, now we say like high allostatic load populations, but really the more elite. So we think astronauts, we think athletes, we think special operators. And because that's a lot of where this emanated is we put a lot of resources into understanding those individuals and how do we optimize the ones that have to perform every single day. But now we're taking the findings that we have from that and trying to extend that to other populations. Because again, at the end of the day, we're all human beings, and we're applying this sports science optimization model to all of the humans. And so we take typically our test beds with our more elite performers, and then we associate that with other populations and work we're doing here with healthcare workers and understanding stress and burnout in nurses and orthopedic trauma surgeons, like how do we optimize their performance, and really that extends everywhere. So really excited about where we're headed, but yeah, we love to make multidisciplinary teams on the performance optimization side. Obviously there's lots that we have to do on Starlab, so excited to have you guys here. Hope that this sparks a ton of conversations. However, any of us at the HPC, myself or some of the others that you may meet here, however we can help make those connections and establish ideas, meetings, opportunities, proposals. That's kind of why we're here. So appreciate your attendance and have a great day.
Okay, thank you so much, Dr. Hagan. And I would also love to take this time to just say a really sincere thank you to the entire team at the Human Performance Collaborative, who have been our steadfast organizing partners for this series. Sam, Jessica, Angela, Dr. Hagan, we really appreciate your support as we've brought this to life. So without any more chatter from me, I will go ahead and introduce our next speaker, Dr. Kenneth Mayuga. Dr. Mayuga is a cardiologist and cardiac electrophysiologist in the Robert and Suzanne Tomsic Department of Cardiovascular Medicine of the Seidel and Arnold Miller Family Heart, Vascular, and Thoracic Institutes. In addition, Dr. Mayuga is the director of the Syncope Center and the Space Health Center at Cleveland Clinic. Dr. Mayuga is a recognized leader in syncope and orthostatic intolerance and has been inducted as a fellow of the American College of Physicians, the American College of Cardiology, the Heart Rhythm Society, and the American Heart Association, the Royal College of Physicians London, And Dr. Mayuga is also a member of the American Astronautical Society and is the PI on an ongoing International Space Station National Laboratory grant. So we're very excited to hear about your work at the Cleveland Clinic Space Health Center. Thank you for joining us today, Dr. Mayuga. Here's your clicker, and then
Good morning. Thank you, Abby, for that kind introduction, and thank you, Dave, Abby, and Laura for the invitation to speak this morning. It's my pleasure to speak with you today about the Space Health Center at Cleveland Clinic. Again, I'm Ken Mayuga. I'm one of the electrophysiologists and cardiologists at Cleveland Clinic. Many of you may be unfamiliar with Cleveland Clinic, so I'll spend a little bit of time talking about Cleveland Clinic. Then I'll talk a little bit more about my background and some of my interests. I'll speak about the Space Health Center and then talk about some of our collaborative efforts as well. But first, I'd like to send my best wishes to Crew 12, who had a successful launch this morning to the International Space Station. So we'll talk a little bit about Cleveland Clinic. Our mission is caring for life, researching for health, and educating those who serve. Our vision is to be the best place for healthcare anywhere and the best place to work in healthcare. We recently celebrated our 100-year centennial. We are now at 105. I'm based in Northeast Ohio at the main campus. We also have 15 regional hospitals in Northeast Ohio. We also have locations in Las Vegas, Toronto, London, Florida, and Abu Dhabi. Our 2025 year-end statistics are still being compiled. So these are the 2024 statistics. At the end of 2024, we had 5,786 physicians and scientists, seeing 3.5 million patients, unique patients worldwide, with 3,600 active research projects, with $520 million in research funding and additional $413 million in philanthropic commitments. In terms of ranking, we're very fortunate to be recognized as one of the best hospitals in the world. We've been ranked number 2 for the 7th consecutive year as of 2025. This is where I work in Cleveland Clinic main campus in Cleveland, Ohio. We have a long history of innovation and research in the cardiovascular realm. This is Dr. Mason Sones, who discovered coronary angiography in 1958. If you know anyone who's had a heart attack, the way we see a heart attack is with coronary angiography. We actually see the blood vessel, we see the blood clot, and therefore we can act upon it and open up and restore blood flow. So that's due to Mason Sones. This is Dr. Renee Favaloro, who reported or published the world's first coronary artery bypass graft surgery in 1968. And so we've had a long history of cardiothoracic surgery innovation as well. And we've continued in 2024, 2025, we were the #1 heart center in the United States for the 30th consecutive year. And in 2026, again, we're very fortunate to be ranked as the #1 cardiology center in the world. So a little bit more about my background and interests. As Abby mentioned, I'm a cardiologist, but more specifically, I'm a cardiac electrophysiologist. So mainly, I deal with the heart rhythm, the electricity of the heart, and what can go wrong with it. These are called arrhythmias. I'm trained in cardiac catheter ablation, which means inserting catheters into the heart and making scars in the heart to treat abnormal heart rhythms. I'm trained in implanting cardiac devices, including pacemakers and defibrillators, which in essence are devices with, again, wires in the heart that give electricity to the heart to prevent the heart from ever stopping, and also can give a large amount of electricity to shock the heart if it goes into a dangerous abnormal heart rhythm. But apart from that, I've always been interested in factors that affect the electrical conduction system of the heart. This is one of my early publications in 2001, and I've just continued to have a fascination for that and continue to publish in that realm. This is one of my more recent publications, the autonomic influence on heart rate, alluding to the sympathetic and parasympathetic influences on the sinoatrial node. So for this interest and for this, I would say, experience in this field, I was named the director of the Syncope Center at Cleveland Clinic. Syncope is an abrupt, transient, complete loss of consciousness resulting from global cerebral hypoperfusion. And to define orthostatic intolerance, because we'll be alluding to this later, referring to this later, orthostatic intolerance are symptoms experienced while upright due to the effect of gravity on cardiovascular function. For example, orthostatic hypotension, which is a drop in blood pressure, or postural tachycardia syndrome, which is a heart rate increase with being upright, again, due to the effect of gravity. This is one of our tilt table tests. As you can see, it's a head-up tilt table as opposed to the head-down tilt table as people do for a microgravity analog. So this is a head-up tilt table test at Cleveland Clinic. We do more than 1,000 of these tests a year using a 45-minute passive protocol with continuous beat-to-beat blood pressure monitoring, 12-lead ECG monitoring, concomitant EEGs, which are electroencephalograms, measurement of catecholamines, carotid massage, and we also do active stand testing. This is one of our abstracts at the American College of Cardiology in 2025, another one in the American Heart Association Scientific Sessions in 2025, and one in the upcoming American College of Cardiology conference in March of this year. We do a lot of invasive cardiopulmonary exercise testing where we have a catheter in the neck and we measure the pressures in the heart and in the lungs, and we see where are the deficiencies, what's holding that patient back, what's holding that person back from achieving the exercise that they should be able to achieve. This is one of our publications regarding dyspnea, which is shortness of breath in what's called a chronic low ventricular preload state, and we'll talk about that in a little bit. So this is a brief diagram of what's involved in this assessment. So if you start off here, venous pooling in the lower body. That means with gravity pulls the fluids down in your body, and they shift from the upper half of the body to the lower half. That's venous pooling. And it leads to low preload. That means not enough fluid coming back up to the heart. That's called venous return to the heart. And that can cause a decrease in stroke volume. That means how much blood is ejected from the heart, going to the body itself again. Deconditioning can also have an effect. Deconditioning also can result in decreased stroke volume. And through a combination of multiple factors, which trying to use the pointer, but you can see here the multiple factors that occur, you can result in shortness of breath. And you can see that in orthostatic hypotension and, again, POTS or postural tachycardia syndrome. This is one of our presentations at the American Heart Association last year, and we have a couple of presentations at the American College of Cardiology later this year. The last time the Heart Rhythm Society had a guideline about POTS was in 2015. And the reason why I bring that up is because one of the strongest recommendations we have in treating POTS is a regular, structured, progressive exercise program for these patients. And it can be quite effective. And the reason why I bring that up is because the cardiovascular deconditioning that can occur can contribute to POTS. And the structured exercise program was initially designed for spaceflight and then utilized in patients with POTS. This is one example of the exercise program here. If you look at the fourth column, you have, in the bottom, you have rowing, swimming, recumbent bike. In month 2, you have an upright bike. In month 3, elliptical or treadmill walking. So a more progressive upright postural challenge as you go along here. So let's transition to space. Astronauts are at risk of syncope and orthostatic intolerance when they transition from microgravity to gravity. This is important for NASA's Moon to Mars objectives. It's important for the industry and commercial travel to low Earth orbit, which is ever increasing. But there are still questions. The why. Why does this happen? Is there a time dependence to this? How do we prevent it? Is exercise enough? How do we treat it? Is fluids enough? There was an interesting publication by Chifu and Ben Levine at UT Southwestern in 2019. They looked at the impact of prolonged spaceflight on orthostatic tolerance, and they note that astronauts returning to Earth usually demonstrate reduced orthostatic tolerance. That means they have difficulty with gravity, difficulty with being upright. But that's usually assessed on a tilt table or just with quiet standing. But they noted that no studies have evaluated post-flight orthostatic tolerance during activities of daily living, and they used ambulatory blood pressure monitoring. So what they concluded in this study was that no astronauts experienced orthostatic hypotension or intolerance during routine activities in the initial 24 hours after landing following 6 months in space. However, there are some limitations and residual concerns regarding what's happening here. And so these astronauts were in space for 6 months. But what happens if somebody's there for longer? Does the same conclusion hold true? All these astronauts underwent individualized endurance and resistance exercise training for up to 2 hours daily as a countermeasure against cardiovascular and other deconditioning. However, what if it can't be done? What if there's an injury or something else that prevents them from doing up to 2 hours of this type of intense training every day? Also, there was a confounder here of immediate fluid loading. These astronauts were usually administered 500 to 1,000 milliliters of normal saline through an IV upon landing, and that can potentially have an effect on the blood pressures within the first 24 hours that were measured in this study. Another consideration is that these were 12 astronauts, which is a small sample size. Granted, this is what we're working with a space type of population, but it's a small sample size, especially for medical studies. And also, these are astronauts. These are rigorously selected, healthy, fit individuals who are highly trained and closely monitored. What happens with the increasing travel to low Earth orbit, where people going up may be less selected? Maybe they have health conditions that they are unaware of. Perhaps some mild venous valvular insufficiency resulting in venous cooling and worsened orthostatic hypotension that you can't train out of. What about conditions that can cause autonomic dysfunction, inhibiting the body's ability to maintain the blood pressure? These can be several mechanisms: neurologic, autoimmune, infectious, metabolic, and so forth. So these types of questions were raised. NASA in 2022 sent out a call to the academic community. They asked for some guidance and responses to their objectives. And I took some time to craft my response and submitted it. And I was fortunately invited to their town hall afterwards. And that was in 2022. And that kind of spurred my interest in this field. So I reached out to NASA Glenn, which is right down the road here in Cleveland, where I am. And I've been working primarily with Jerry Myers at NASA Glenn. I also reached out to Professor Simon Evans, who has more than a decade of experience with the European Space Agency. And I also connected with Virginia Watering at the International Space University in France, who is the chief academic officer there. And so I applied as a principal investigator to an ISS National Lab grant, and I was fortunate enough to receive it with a lot of help, as you see here. Let's see if this works
Another
here.
great example comes from the Cleveland Clinic Foundation. The Space Medicine Education for STEM Inspiration Project looks to introduce PhD and MD students to space medicine, space-related careers. The curriculum will cover cardiovascular anatomy and physiology during gravitational changes.
Thanks so much for those project examples.
All right. So we're hosting a 1-week seminar, Space Medicine Education for PhD and MD students, and that's scheduled for this June. This is what we're doing. We have 5 days. We have morning lectures. We have afternoon lab practicals. We have a lot of interesting things. We have a lot of guest speakers from NASA Glenn. We have a former astronaut. We have a lot of people involved in the space industry and exposing these PhD and MD students to the exciting fields and careers in space medicine. And so we also have a very unique tour of NASA Glenn facilities just for our students in this course. So let me talk a little bit about the Space Health Center. I'm the director, and I'm fortunate enough to be supported by many cardiologists who are very interested in this. I have people from preventive cardiology, clinical cardiology, heart failure cardiology, cardiac rehabilitation, sports cardiology, interventional cardiology, cardiac imaging, cardiac electrophysiology. So it is very cardiology focused, but I'm already receiving interest from my colleagues in pulmonology, gastroenterology, and so forth. So we are very new, but we are very rapidly expanding, let's say. Now, it is worth realizing that every cardiologist on this list has a full clinical load. That means they see patients. For example, I myself see, just for my syncope practice, apart from electrophysiology, for my syncope practice, I see more than 1,000 patients every year with syncope and orthostatic intolerance. Why does that make a difference? Why does it make a difference to see patients? Because of why we do what we do. People on this list are not researching for knowledge's sake. We're doing this because each and every day we see patients who are impacted by disease. They're suffering and their lives are affected. And so this is what drives us to seek answers, not only to, again, advance medical knowledge for its own sake, but to ultimately help others along their journey. And so a lot of these people on this list and in our department in general are awfully good at what they do. You can even say that they wrote the book, because this is the book. Manual of Cardiovascular Medicine. This is the sixth edition here. So I was invited to NASA Glenn, and I met with some brilliant individuals there and brilliant researchers in their research teams. And what I did is I pulled up the Human Research Roadmap and looked at NASA's identified gaps in knowledge. And so, for example, let's see here. Orthostatic intolerance, risk of orthostatic intolerance during re-exposure to gravity. This is what I do every single day. Every single day. Risk of cardiac rhythm problems. Again, electrophysiology, this is what we do. So they're very interested in NASA about the risk of something called atrial fibrillation. Atrial fibrillation is an abnormal heart rhythm that occurs in the top of the heart. And they were considering using something called a cardio device, and they asked me about it. And it turns out Cleveland Clinic was one of the first people to study this and report on this device in atrial fibrillation. This is the Cardia device here. And so I was able to meet with the inventor and founder of Cardia that very week in person, and spurred ongoing conversations. I'm going to run through some of these other identified risks here. Radiation. So there's a big concern about how does radiation affect the body, space radiation. And it turns out Rohit Mudgil has experience in radiation. He's a consultant for NASA. This is one of his publications where he mentions radiation and about the journey to Mars. Let's talk about reduced cardiorespiratory and musculoskeletal fitness. We have Eric Van Eidersen in cardiac rehab. This is one of his publications, Unraveling the Complexities of Exercise Physiology in Heart Failure, begin with deconstructing the Fick principle. He's a very smart individual. We have a concern here for impacts due to altered immune response. David Zeider, this is what he does for his research. This is one of his publications, Crude Lymphocyte Levels, Can the Past Accelerate the Future in Preventive Medicine? What about something a little bit more esoteric, something a little bit more apart from typical cardiology? The long-term health effects and performance effects due to host microorganism interactions. Turns out that's Bob Keith's research. He's an electrophysiologist like I am, but this is what he does. This is one of his publications. Carnitine in omnivorous diets induces an atherogenic gut microbial pathway in humans. A little bit more. We need to characterize the extent to which spaceflight alters pharmacokinetics and pharmacodynamics. We approached that. This is our first publication from the Space Health Center that was just published last month. Anticoagulants for the prevention and treatment of venous thromboembolism in humans exposed to microgravity. And this is in direct response to what happened here. This is a publication, New England Journal of Medicine in 2020. Approximately 2 months into an ISS mission, obstructive left internal jugular vein thrombosis was suspected in the astronaut during an ultrasound examination that was performed as part of a vascular research study. This was not clinically spurred. The astronaut reported no headache or worsening of facial plethora that's common to conditions of weightlessness. So this was part of a study. They found it incidentally, but they found a big problem. They found a big problem that was not anticipated. So in our publication, we have some authors with unique qualifications. We have Dr. Andrew Winard Brewer, an expert on systematic reviews for space medicine. We have Dr. Katie Greenlee, a clinical pharmacist and board-certified cardiology pharmacist. We have Jerry Myers, as I mentioned, from NASA Glenn Research Center, an expert in model and simulation applications, quantifying and addressing the risk in human spaceflight. Virginia Watering was the former pharmacology discipline lead at NASA Johnson Space Center and has experience with research studies in ISS, and of course myself as well. So what we did is we used the PRISMA method and we scoured the literature, Medline, Embase, Scopus, Web of Science, Cochrane Library, CINAHL, NASA Technical Reports Server, the ESA Archives, clinicaltrials.gov, NASA Life Sciences Data Archive, ESA Erasmus Experiments Archive, ISS Publications Archive, German Aerospace Center database, and NASA Space Station Research Database. And what did we find about the efficacy and safety of pharmacologic anticoagulation for the prevention and treatment of venous thromboembolism? We found nothing, zero. So we went ahead and did a narrative review. We talked about the venous changes that occur with microgravity, the changes in the jugular venous pressure, the jugular venous cross-sectional area. These are experiments done in parabolic flight, in space flight, and analog with head-down tilt table tests, analog dry immersion. We described the coagulation system changes that have been reported, and fibrinogen, et cetera. We came up with our own schematic on space-specific risk assessment for venous thromboembolism. And we also talked about treatments with experts we had in our author list. We talked about, is a direct oral anticoagulant preferred, et cetera, et cetera. And so in summary, microgravity induces venous stasis, endothelial dysfunction, hypercoagulability. There are diagnostic challenges in space, in the ISS, in a limited compartment where you can't bring everything up there with you in space. There's limited ultrasound capability and practical D-dimer assays. There's only one documented case of in-flight thrombosis, but this was unsuspected. It was not clinically apparent, so there could have been more. We just don't know. And we talked about potential countermeasures, and we talked about pharmacokinetic studies and anticoagulation trials are sorely needed to safeguard the astronaut health on future long duration missions. So it's been a whirlwind for me and for the Space Health Center just in the past year because we're very new. I was invited to the Space Technology, Glenn Space Technology Symposium in September of last year. I presented at the ISS, our Research and Development Conference in September. I was invited to a wonderful call by Dave, Laura, and Abby, the Starlab University Coalition call, the first Starlab Space Research Universities meeting. And as they mentioned, it was, did you mention it? But maybe we talked about it beforehand, but it was an amazing call with a lot of universities across the globe. And of course, this conference. So thank you so much for inviting me to this conference. I'm very excited about our Space Med Ed program in June, and thank you for your attention.
Okay, thank you so much, Dr. Mayuga. That was absolutely fascinating. And I have to say that it was really fantastic as well to hear about how the geographic connection with Glenn Research Center was able to help you develop some of those partnerships as you progressed with your research interests in space and at the Cleveland Clinic Space Health Center. We have a couple of minutes before our next speaker for any directed questions to Dr. Mayuga. So if anyone in the audience has a question, we will go ahead and pass around a mic. But if there are no directed questions and we're saving them for the end, that is also fine. So any questions? Okay, yes. Sam, do you mind taking the mic to our colleague in the back? Okay, and if you want to just come up here and... Sorry, I thought you were free.
Hello. So with the heart sheets and any of the organoid development work, have you done much to kind of correlate that so that you can make use of those? I mean, there's, it's the organoids has come such a long way now, where they're so diversified and so many good groups working on that. And then just cell culture in general, the tech to sustain that in space flight is so far advanced now. Can you speak a little bit to kind of tie in that back to what you're doing? Because it seems like big opportunity there.
Great question. Great question. And if I can understand your question a little bit further, it's regarding experiments that have been, that are ongoing in ISS. And, I can, first of all, just say that we are not currently doing those experiments, but I can say that I attended one of Abby's workshops. And when, this workshop was about doing the, space biology experiments, and there was different companies saying how they help people do these types of experiments. So I found that fascinating. So if you want to talk offline afterwards, I'd be happy to learn a little bit more. But this is a very exciting field, as you have mentioned, and I learned a lot from that workshop, and we're very excited to see how we can contribute there as well. Thank you.
Morning, Neil Johnson, managing partner, Lawrence Evans and Company, a healthcare investment banking group. Also put out a bioastronautics, more from an investment perspective this past year. And so a lot of comments around, the radiation you talked about, and people I've talked about within the, aerospace defense, and just concerned about radiation, the challenges still, whether it's, Moon, Mars, et cetera, affecting the body, and how do we overcome that?
Great question. And, I already, we've already started looking at that in many different ways. We as a collective, I would say. But Rohit Mudgal has done some work in radiation and the effects on the cardiovascular system. But beyond that, just radiation itself, how it affects the body. I believe when I attended this meeting with Abby's team on was it Wednesday, they had some description about Starlab and how radiation can be thought of, and whether there's shielding involved and things like that. So that's going to be important as a long-term type of risk mitigation project. And how it affects the body itself, it's not just limited to the heart. It's going to be across the whole body, how it affects the eyes, how it affects the brain, things like that. So, a lot of work to be done. I'm not familiar with all the work, the body of work in terms of radiation, different effects of the body. We're still focused on the cardiovascular system, but we are expanding rapidly into other organ systems. So again, happy to speak with you as well. Thank you very much.
You alluded to microbial interactions in your talk. And so I was wondering, does the human microbiome change during the very long?
Great question. And, among the things that I've learned in these types of conferences and sessions is that it's not as clean on the ISS as what we had hoped. And so the microbiome is something that's very, very studied. I think Ohio State is receiving the filters after when they come back here and looking at the microbiome of that and how it, just some clues and some discoveries there. Does the microbiome of the human change? I would say as a general concept, it probably does. I'm not aware yet of the specifics, and I'm sure people at Ohio State here can teach me a little bit more about that. But that's a great question, and probably people in the audience can shed a little bit more light than I can. But thank you very much.
Amazing. So I think that's all the time that we have for questions. Thank you so much, Dr. Mayuga. We're thrilled to have you here today, and we're thrilled to have you in Cleveland Clinic and all the great work you're doing be part of our university partnerships that we're building out through Starlab as well. We'll get to hear more from Dr. Mayuga during the panel at the end, but one more round of applause. Thank you. Now, bear with us for a moment as my colleague works to get our next speaker set up, who will be joining us remotely from California today due to some travel issues. However, while we work on getting that set up, I would like to just mention a couple of things that came up during the Q&A period as well. Notably, if there are any questions or interests in space medicine that you have that are not the particular specialty of our speakers here today, please still feel free to ask those, and we'd love to have that conversation be known to us. And feel free to reach out to myself or any of my colleagues here at OSU on the Starlab team, and we would be happy to try to connect you to researchers who are working on those specific topics. We are really hoping to create an interconnected and communicative web of space researchers. So always reach out, and we're happy to try to make any of those connections. For example, I know a number of folks who are working on space microbiome as it relates to ISS, a number of folks who are working on radiation exposure and how we can improve our protections for next generation astronauts. Happy to make any of those connections. I think we're ready, right? Yes, okay. So one moment. Arun, would you mind unmuting yourself? There we go, perfect. And
Sure.
then,
Hopefully you guys can hear me.
Yes, perfect. So our next speaker is Dr. Arun Sharma, who is an associate professor at Cedars-Sinai, affiliated with the Board of Governors Regenerative Medicine Institute, the Smith Heart Institute, the Cancer Institute, and the Department of Biomedical Sciences. Dr. Sharma is the director of the Center for Space Medicine Research and the director of the CIRM Shared Resources Lab. Dr. Sharma's lab focuses on the applications of human-induced pluripotent stem cells for modeling cardiovascular diseases in vitro. In 2016, Dr. Sharma led the first long-duration cell culture experiment in space, sending human stem cell-derived heart cells to the International Space Station. Dr. Sharma earned a bachelor's degree in biology from Duke University, a PhD in stem cell biology and regenerative medicine from Stanford University, and completed a postdoctoral research fellowship in cardiovascular genetics at Harvard Medical School. Dr. Sharma is an internationally recognized leader in space biosciences. And I have to say, I've seen presentations from Dr. Sharma before as well, and we are all in for a real treat because the research that he and his group doing is really fascinating. And we're all really grateful for you joining us today, especially with how early it is out on the Pacific coast. So thank you, Dr. Sharma. And without any further ado, please go ahead and take the stage.
Sure. Well, thank you so much, Abby, for the really kind introduction there. And apologies again for not being able to join you in person and giving this talk virtually. You know, when the kids get sick, chaos ensues, as parents in the audience, I'm sure, are aware. But regardless, happy to chat about the work we've been doing over the last 10 to 15 years in this area of stem cell research and biomanufacturing in space. And I'll give a snapshot of all the different projects we've done and are continuing to do in this area of work. So as Abby alluded to, I'm a stem cell biologist by training. My lab predominantly focuses on this very special type of stem cell, as I'm sure a number of folks in the audience are familiar with. These are human-induced pluripotent stem cells, or HIPSCs. They're first discovered in 2006 and are actually the foundation of a Nobel Prize that was awarded in 2012. So just a 6-year gap in between discovery to Nobel Prize tells you the promise of the technology. And just as a stem cells 101, just to get everybody on the same page here, to make these induced pluripotent stem cells, you can take a small sample of someone's own skin or blood and then, quote, reprogram those skin or blood cells into these powerful pluripotent stem cells, which means that they can give rise to really any somatic tissue in the human body, whether it's heart tissue, brain tissue, liver tissue, you name it. You can make these personalized tissue types from these induced pluripotent stem cells, again, derived from a small sample of patient's skin or blood. I'm a cardiac biologist, as was described, so my lab has become really good at making patient-specific human cardiomyocytes or heart muscle cells by the billions. I mean, these protocols have been refined over the last 20 years, and now even the high school students in my laboratory are able to routinely make functional cardiomyocytes, patient-specific cardiomyocytes from these iPSCs. And the applications are thought to be threefold here. First is for autologous cell therapy. We and others have started investigating this and have been investigating this, basically using patient-specific iPS cardiomyocytes as a means to replace lost cardiac tissue after an event such as a myocardial infarction. The heart is one of the organs in the body that actually does not have a strong innate regenerative capacity. So once you lose those muscle cells, you need to find a replacement cell source. And one thought is patient-specific cardiomyocytes may be that cell source. My lab predominantly focuses on the latter two applications, though, which is for cardiovascular disease modeling, using these patient-specific heart cells to recapitulate phenotypes of cardiovascular disease in a dish. So, for example, if someone has a genetically induced arrhythmia or a heart rhythm problem, you can reproduce that arrhythmia in a dish by making that person's own iPS cardiomyocytes using these protocols that I described. And then finally, drug screening and drug discovery. Since this is pretty much the only way you can mass produce cardiac tissues for research purposes, these cells are of significant interest, not just for academic uses, but for pharmaceutical applications and being able to identify new compounds that would be able to improve heart function. Or something else that my lab focuses on is using these cells to find safer versions of existing, say, chemotherapeutic or cancer agents out there that don't do damage to the heart. I'm not going to talk about that today, but that's a separate area of work in my lab. And it's more than just growing these cells in 2 dimensions in a dish. Now, as was alluded to before, the next generation of model systems that's utilizing these iPSCs are 3-dimensional systems, such as organoids and spheroids. And this is just a snapshot of some of those systems that are in my laboratory. Of course, we're not 2-dimensional physiologically. We're, of course, 3-dimensional. The heart is a 3-dimensional organ. And so these 3-dimensional model systems, such as cardiac organoids and spheroids, are better physiological approximations of the developing human heart, and they incorporate the different cell types that are found in the heart as well. So not just the muscle cells, the cardiomyocytes, but the blood vessel cells, endothelial cells, support cells, fibroblasts, and so on. And also just highlighting some of the folks doing the work. We also have organ-on-chip systems that we've worked on for a few years in our laboratory. These are engineered approaches where you can grow multiple cardiovascular cell types on a single integrated chip. And this is pretty powerful, again, for toxicology screening and for various forms of disease modeling as well. Now, it's more than just growing these cells in a dish. We are certainly using stem cells for direct clinical applications here at Cedars-Sinai. And this is a slide from my colleague and a mentor, Dr. Clive Svensson, who's our director of the Regenerative Medicine Institute here at Cedars-Sinai. Just as a snapshot of some of the work that we're doing in our hospital here. For example, his lab has for years pushed forward this clinical trial transplanting human neural stem cells, neural progenitor cells for treatment of amyotrophic lateral sclerosis, or ALS, currently in the phase 1/2 clinical trial funded by CIRM, California Institute for Regenerative Medicine. And so again, just a way to highlight that the work that we do is not exclusively in vitro. We're bringing a lot of these treatments, stem cell-based treatments, to the clinic directly in our hospital as well. Now, like I said, predominantly the work that I do in my laboratory is in vitro, and this is just a slide showing the evolution of the stem cell technologies and pluripotent iPS technologies over the last 2 decades. Like I said, these cells were first described in 2006, 2007, and over the course of time, these systems have become much more complex as opposed to growing simple 2-dimensional cells in a dish. Now we can incorporate them into 3D engineered and 3D printed systems, microfluidic chips, as I alluded to, and certainly organoids have taken the stem cell field by storm as well. And I'm going to be highlighting those in some of our space studies as well. Now, bringing it back to the space side of things, since that's why we're all here, I suppose, we have been able to show, we and others have shown that microgravity can dramatically alter basic stem cell properties and stem cell mechanisms. So the definition of a stem cell is a cell that can recapitulate or reproduce itself indefinitely, and also importantly give rise to downstream cell types, whether it's heart cells, liver cells, and so on. And these properties of stem cell proliferation, differentiation, are indeed dramatically altered in a microgravity context. And this is not limited to a single stem cell type, whether it's pluripotent stem cells or iPSCs, but also multipotent blood stem cells have been investigated in this way. There's a lot that changes when you take gravity out of the equation. And from the fundamental perspective, it has to do with changes in mechanotransduction, or how the cells actually sense their environment and respond to those mechanical cues appropriately. Because of these changes in stem cell properties, this allows us to model human disease and physiology in unique ways in space and in microgravity. And some of these examples have come up before, of course. Astronauts experience bone and muscle degradation pretty rapidly in microgravity and over the course of a stay aboard the ISS, for example. And we can use that to our advantage in a way, since we can study disease processes for terrestrial equivalent diseases such as sarcopenia and osteoporosis potentially faster in a microgravity context by distilling those disease mechanisms down to the cellular level. So this is not just the case for studying, say, sarcopenia or muscle wasting, which happens terrestrially, but also forms of immune dysfunction, which certainly happen on the ISS as well as terrestrially. So there's a lot of parallels between terrestrial disease mechanisms and what we see with astronauts aboard the ISS, for example. And indeed, there are a lot of downstream applications for these stem cell-based approaches for drug development, countermeasure development, personalized medicine, especially if we're using induced pluripotent stem cells, which are inherently personalized since they're derived from a person's own skin or blood. There's a number of downstream applications that we can use these cells for. And one thing that I'm quite excited about is not necessarily the negative side of microgravity, or the negative impacts of space on human physiology, but how we may be able to harness microgravity to perhaps bioengineer or tissue engineer unique products in space that we may not be able to on the ground. And over the course of the presentation, I'll talk about some of the projects that we've done in that particular area, especially focused on a NASA in-space manufacturing award that we've had for the past 5 years or so. So indeed, stem cell research has been conducted aboard the International Space Station and aiming to address a number of the questions that I alluded to in the past few slides. These are just some examples of NASA astronauts conducting our studies and other studies aboard the ISS, Jessica Meir, Peggy Whitson, and Kate Rubins as well. And we've had the opportunity to work closely with these folks for the course of multiple experiments. And a majority of the work that I'm going to be describing here has been funded by the U.S. National Laboratory as well as NASA. Indeed, we have been quite active in this space, and just to highlight that we've had 9 to 10 different missions aboard the ISS focusing on various stem cell mechanisms, whether it's stem cell differentiation, transfection, automated cell culture, production of pluripotent stem cells. And this is going to be quite a busy year for us as we have additional projects lined up to launch on SpaceX 34 and 35 as well. I'll take a step back and talk about a foundational study that really has laid the framework for the subsequent 10 years of work that have been done in my lab. This was what Abby alluded to, actually, this 2016 study where we sent iPS-derived cardiomyocytes to the International Space Station. And this was actually the first long-duration cell culture experiment done on the ISS for a period of more than 30 days. So this is actually work that was initiated when I was a grad student at Stanford, and the overall approach was relatively straightforward. We created patient-specific cardiomyocytes from 3 separate individuals, sent a sample of these cells to the International Space Station, as well as a sample that we grew in our laboratory at Stanford, and then conducted a number of downstream analyses on these cells as they were being grown aboard the ISS, including functionality analyses, contractility, structural analyses, calcium imaging, and genetic and transcriptomic analyses as well. Our greatest partner in this entire experiment was none other than astronaut Kate Rubins, who I alluded to in the previous slide. She's one of the few NASA astronauts who has a strong biomedical research background and training, and was a PI at the Whitehead Institute in Boston before becoming an astronaut herself. So she was a tremendous resource to this particular study, indeed. I'm not going to go too deep into that study since the results have been published there, but just a few conclusions here, laying the groundwork for what we're doing currently. So we were able to show that patient-specific cardiomyocytes and these advanced cell types could be grown long-term aboard the ISS, again, for a period of more than 30 days. The cells actually exhibited alterations in their functionality and contractility within days of spaceflight. Interesting thing that we saw was some of those changes actually reverted back to normal when the cells came back to the planet. There are also significant changes in gene expression in spaceflight, especially those related to metabolic pathways. And big picture, we were able to show that, yes, this could be a useful model system to study the effects of spaceflight and microgravity on the human heart at the cell-based level, at the cellular level. And subsequent studies have followed up on this using patient-specific stem cell-derived osteoblasts and osteoclasts for bone modeling, and other myocyte cell types for looking at musculoskeletal degradation, and neural organoid models as well. So it was a really great foundational study in that way, and feel free to take a look at the details as well. And certainly, there's a lot of room for improvement here. This is a very simplified study, basically looking at just two-dimensional cells being grown in a customized 6-well dish. If we want to go to the future and really scale up in these experiments, we have to consider automating some of these processes, automating cell culture approaches, since crew is obviously very busy. Their time is at a premium, and automation of approaches will allow us to get around some of those crew time constraints. As alluded to, there's a lot of new systems out there, not just two-dimensional cells in a dish, but tissue-engineered and three-dimensional organoid approaches, which are starting to incorporate into the next phase of this work. And if we go towards manufacturing and actual production of stem cell therapies and organoids and so on, we got to think about improving the scalability of some of these experiments and overall throughput. And some of the work that we've done recently has focused on that. I wanted to highlight a pretty amazing resource that we have on campus here at Cedars-Sinai, which is our CGMP grade biomanufacturing facility. It's an on-campus cell production and then viral vector production facility. They actually serve as a CRO, a contract research organization, for companies, other academic institutes that are hoping to develop their own cell therapies or their own, GMP grade products. They can make those for them and ship them back to different locations around the world. They're also an amazing iPS production lab. They make thousands of different iPS, patient-specific induced pluripotent stem cell lines, for use not just in clinical trials at our hospital, but for the various in vitro disease modeling projects that my lab and many other labs here at Cedars-Sinai are doing. And yeah, so they've been really critical in helping us brainstorm some of the ideas for taking GMP grade cell production into space, for example. And why do this, right? Why send these cell-based products or three-dimensional organoid and tissue products to microgravity? Like, what is the advantage here? Well, our hypothesis is that there's a few different advantages. One, we may be able to grow the undifferentiated version of these stem cells better in space, so they may be able to grow in unique ways that improve their capacity to actually turn into downstream cell types. Again, if you distill it down to the fundamental principles, it's because of changes in mechanotransduction. And our biomanufacturing center has already started exploring this through multiple projects to the ISS, which I'll highlight shortly, looking at the expansion of neural progenitor cells as well as 3D induced pluripotent stem cells. We think that microgravity could facilitate the scale up of some of these cell-based products. And interestingly enough, when we're trying to scale up the production of these 3D organoids and associated tissue types here on the Earth, we actually simulate microgravity. So we can force these things into clandestats and suspension bioreactors to actually help facilitate their overall growth and their proliferation. Sometimes without even realizing that indeed we're using a microgravity simulator to do that. So our crazy idea was to try the real thing and actually attempt to scale up the production of these organoids in space in true microgravity. And there's also some analyses that we're doing that's looking at the overall genetic integrity of these cells and tissue types in space and how that may be able to be improved by growing these cells in space. So just highlighting a few of the missions that they've done over the last few years, 3 different missions in collaboration with Space Tango and with NASA, looking at automated cell culture, 3-dimensional neuroprogenitor cell culture, and so on. Ultimately, their goal is, again, focusing more on the automated cell culture side of things. And there's still certainly an advantage for having manual astronaut intervention in the science that we do, especially if it's more complex and less amenable to be immediately automated. But their approaches are more in the realm of automated manufacturing here. And an ultimate goal could be the creation of a GMP grade satellite. So a satellite with appropriate sterility and GMP grade criteria that would be able to serve as a site for mass manufacturing of the stem cell products that ultimately could be used here clinically at Cedars-Sinai in our hospital or at other locations as well. So I also wanted to highlight the project that my laboratory is leading, which is also an in-space biomanufacturing project, but it's more focused on manual cell culture and more targeted differentiation of iPSCs into organoids and actual production of iPSCs in non-automated ways in microgravity. So as I alluded to, we have great expertise in iPS-induced pluripotent stem cell cultures, and we want to define the production modalities and the basic fundamental cell transfection modalities for iPS culture in microgravity, ultimately looking towards scalable production in collaboration with our biomanufacturing center. So the project here, which has been a 4 to 5 year project in collaboration with NASA and Biosurf Space Technologies, was basically taking induced pluripotent stem cells and in the first aim, just understanding at the most fundamental level how do they actually grow over extended exposure to low gravity. So that's something we wanted to characterize in the initial missions that we were doing. Just what is the ability of these stem cells to be, say, transfected with DNA in microgravity, and how do they change their cell proliferation profiles in space? The second name of the project, which was done in a subsequent mission, was the actual production of iPSCs in space. What the Biomanufacturing Center was describing was already pre-made induced pluripotent stem cells that they sent in 3-dimensional spherical form. Here in this aim, we were actually trying to make stem cells in space for the first time. And then the final aim, which is something that we're in the process of doing right now, and have actually had a mission just wrap up on SpaceX 33 is the differentiation of those stem cells into cardiac and neural tissues in space. And I'll talk a little bit about that. So here's the team that has been leading these efforts. And this is a collaborative effort with myself and also Clive Svensson here at Cedars-Sinai, as well as Maddie Arzt and Maida Mosna from my team. And like I said, this is a collaborative effort with BioServe Space Technologies in Colorado, as well as with Axiom Space, who are our partners for this in-space manufacturing award. The first mission, which I'll highlight, was the Axiom precursor mission, or AX2, where we actually demonstrated stem cell transfection in microgravity. It was kind of a foundational mission for the subsequent two, which I'll also highlight, which is IPS production on NG-21, as well as organoid production on SpaceX 33. So we'll start there with the AX2 precursor mission. Like I said, a relatively straightforward mission here. We just wanted to demonstrate stem cell growth and DNA transfection in space and see if some of those mechanisms were altered compared to a terrestrial environment. And these, things like DNA transfection, these are very foundational approaches for more advanced applications such as genome editing or IPS production. You got to be able to show that you can introduce DNA appropriately into these cells in a microgravity context before you can look at more advanced applications downstream. So we worked together with the Allen Institute in Seattle, which is an amazing nonprofit research institute. They have custom pluripotent stem cell lines, as you can see there on the right, have fluorescent reporters built into those lines, which allows us to visually track the division and the health of these stem cells by using microscopes aboard the International Space Station. Just some scenes from the mission itself. So these are our astronaut partners from the AX2 mission, including Peggy Whitson as well as Rihanna Barnawi, who were able to do the hands-on cell culture for us. And again, this was not automated cell culture. We were doing something a little bit more intricate here, so we needed more manual crew intervention for these sort of studies. I'll walk you through some of the results that we got from this particular study. It was actually just published in late in 2024. So indeed, we're able to show successful production of stem cell-derived spheroids in space, transfection of DNA into these stem cell cultures in space, and then a hardware development story, which I thought would be of interest to the folks here in this audience, was the actual use of terrestrial off-the-shelf hardware for routine cell culture in space. So as many folks in the audience know, when we're doing life sciences in space, a lot of times we have to customize the hardware that we use to actually grow the cells in the appropriate context. But here we're able to use a trick in surface tension that I'll describe in a couple of slides to actually use off-the-shelf hardware that's routinely used for cell culture here on the Earth. And so, yeah, I can actually describe it right here. A few years ago, Kate Rubins took a standard 96 well plate to the International Space Station and wanted to see if she could pipette fluids into that well plate, which, as the bioscientists in the audience know, this is a device that is found in pretty much every single cell culture laboratory in the country and in the world. Very cheap, very straightforward and high throughput, easy to use, and is easily coupled with other downstream high throughput approaches. And so she was able to show just by pipetting some colored liquids that indeed you can retain fluids into these small wells. And the size of the wells is really the key here, is because it's surface tension that's able to keep the fluid in those wells. And that's in contrast to larger well plates like a Petri dish or a 6-well plate that would not be able to retain fluid appropriately just because the well size is big and the surface tension wouldn't be able to retain it. So that was really the foundation for the studies that we did on AX2. So instead of just using empty plates of just liquid, colored liquid, we wanted to grow cells and organoids and spheroids in that same format. So, and again, it was really surface tension that was the key here. So here's the experiment that we did on X2, relatively straightforward experiment over the course of less than a week. We thawed these fluorescent reporter-induced pluripotent stem cell lines on the ISS. and introduced DNA into these cells to determine their transfection efficiency, conducted a number of imaging analyses to verify that transfection, and then did something similar with a comparable cell line of SOX2 fibroblasts, which are the differentiated cells. So the first thing that we saw was pretty interesting in contrast to what we were seeing on Earth, which is two-dimensional adherent culture of these stem cell lines. In space, we saw rapid formation within hours of these three-dimensional spheroid stem cell cultures. So these iPSCs spontaneously formed three-dimensional spheroids after thawing them in these 96-well plates on the ISS. Also, we were able to demonstrate the successful transfection of RFP plasmid DNA into these stem cell populations on the ISS, both at the stem cell level and also at the fibroblast level, as you can see here. And that's foundational for the subsequent studies that we did looking at stem cell production, iPS production, because you need to be able to transfect DNA into these cells to make that process happen. So that's just a snapshot of that study. In my mind, the technical advancements there, the use of the 96-well plates was just as important as the cell biology that we observed, because a goal of the studies that I want to do is to democratize life sciences in space and avoid the use of custom hardware whenever possible. And if we can use a 96-well plate, which is less than $1 a pop, for routine cell culture in space, then I think that allows a lot more people to potentially do life sciences in space, which is, I think really important. Next, I'll move on to the iPS production study that we did on NG21. This is the first production of pluripotent stem cells in space. And we took basically a reprogramming plasmid, which we used to make iPSCs terrestrially here in a biomanufacturing center, and sent that to the ISS, International Space Station, and introduced them into these fibroblast populations to see if we could transform them into functional induced pluripotent stem cells in space. And again, our readout to see if this was actually possible was the expression of this green fluorescent protein, or GFP, tied to SOX2, which is a marker of stem cell populations in space. And this is important because we think demonstrating production of iPSCs in space will unlock downstream applications for making stem cell therapies, advanced disease models, tissue engineered approaches, and so on. So being able to actually make the stem cells in space is foundational for all of that. And and indeed, we were able to accomplish that. And you can see some of the stem cell colonies that we were able to create, validated by our biomanufacturing center here at Cedars-Sinai. You can see markers of bona fide stem cells such as OCT4, SOX2, NANOG. These are things that the biomanufacturing center does all the time to actually validate the production of stem cells terrestrially. They've been doing this thousands of times for different stem cell lines. And these, again, were the first that we were actually able to make from scratch in space. So we actually have a number of these lines banked and frozen in our biomanufacturing center, ready for distribution, and are in the process of doing some further characterization of these lines to validate their production. And the last thing I'll mention here, the last project I'll talk about, is focused on our most recent missions here. This is the production of organoids in space from scratch. These are three-dimensional heart and brain tissues that we're making from iPSCs, induced pluripotent stem cells. We had a pretty, successful mission on SpaceX 33 and are actually doing a reflight scaled up version of this organoid production mission on SpaceX 35 in the summer as well. So organoids, as a number of us in the audience are aware, have taken the stem cell and biomedical research fields by storm. Incredible applications here for disease modeling, for cell therapy, in vitro human tissue production, and so on. And there's certainly an advantage to growing cells in these three-dimensional ways as opposed to two-dimensional cells in a dish. But there are limitations of organoids terrestrially, namely their immaturity, their lack of complexity, their lack of ability to harbor blood vessels in a number of ways, and perhaps most importantly, their homogeneous, scalable production. And that's something that we're hoping microgravity could help us do, right? by using microgravity as this natural suspension bioreactor, perhaps we can make more or better organoids in space than we could on the ground. That was our hypothesis. And so, indeed, we did send IPS lines to the International Space Station and then initiated a differentiation process to brain and heart organoids and conducted a number of genetic and imaging analyses and are in the process of doing our analyses, deeper analyses right now. But I can say that we had an exponential increase in the number of organoids that we were able to create in microgravity as opposed to terrestrially. And perhaps the next time I'm here, I'd be very happy to show the details of those results. But the homogeneity and the scale of the production that we got for these three-dimensional organoids was pretty impressive compared to the ground side controls. And for the sake of time, I'll start wrapping things up just to share the things that we're able to accomplish here. We're able to demonstrate the use of commercial off-the-shelf hardware for cost-effective, high-throughput biology in space. We're able to transfect DNA into stem cells in LEO for the first time. This lays the foundation for advanced applications like CRISPR genome editing, for example. We actually made iPSCs in space for the first time and have these cells frozen down in our laboratory for distribution. And we saw an enhanced production of organoids in space, again, in cardiac and brain tissues. And we're excited to refly this mission in the next few months as well. I'll leave you with this one last thing here. Based on these scientific data and projects that we've been doing, we've established a Center for Space Medicine Research at Cedars-Sinai, which I'm fortunate to direct, where we have institutional support to continue growing our space research programs as well as educational programs. We're aiming on establishing a master's program in space biosciences and have already created a regenerative medicine master's program with a number of space medicine courses in there. And have a number of strengths, namely that we're in LA, which is, of course, a new hub for space tech, and have started collaborating with a number of companies just down the road from us here at Cedars-Sinai. And with that, I just want to thank the funding, supporting the work, and the folks doing the work, as well as all of our collaborations. And apologies for running a little long, but happy to take some questions if there still are some.
All right. Thank you so much, Dr. Sharma. We really appreciate your time. And special thanks for joining us today, despite having a sick kiddo at home. That is so difficult, and it's generous of you to still be here with us today. We do have time for just a couple of questions. And I do want to mention that for anyone who is joining us remotely over Zoom, please still feel free to ask questions. We welcome you to put them in the chat, and one of our team members who's here in person will ask them on your behalf. So I do see a couple of questions. My colleague Sam will be running the mic around the room to grab those questions for Dr. Sharma.
Thank you. I'm a big workforce advocate in Central Ohio. My name's Derek Galloway, and I had a question about where you think the biggest gaps in university development and STEM programs are and the needed workforce of the future.
Yeah, it's a really important question. I think part of it is, getting the word out to the folks, the trainees in the audience and the trainees in the communities to show them that this is a valid career path, right? And that's doing outreach even as early as the high school and middle school levels to 20 years ago when I was first getting started in this, I didn't really have someone to point at and look to be like, hey, I would love to follow that person's career trajectory. Whereas now I think there's a lot more possibilities thanks to the growth of the commercial space industry. So, I think that evangelism is really important, getting out into the community and telling folks that this is a possibility. And something that I do a lot in my laboratory is not just, tell people about the work, but actually show them and bring them on board. So we have a number of high school interns and college interns who are helping execute a number of these space projects, and we need all the help we can get. So it's a combination of things, but it really comes down to showing people the opportunities and giving them ultimately the opportunities.
Dr. Sharma, thanks for everything that you've done for this field of study and also your presentation today. I'm Tim Copra from Voyager Technologies, and going around with our international partners, I've seen a lot of progress internationally. I spent some time in Abu Dhabi where I've seen some pretty interesting development work. I'm curious what you've seen internationally with this type of research.
Yeah, I think there's tremendous growth. And the stem cell side of things, I think certain countries have really taken the forefront in this area of study. I can point to Japan. Those iPSCs, induced pluripotent stem cells, were actually first described in Kyoto, Japan, 20 years ago this year. So they have really taken a major investment in the organoid and stem cell manufacturing and space side of things, and also have had contacts with folks in the Middle East who are setting up their own initiatives in Saudi and various other initiatives, Saudi Space Agency and so on. So, I think part of it comes down to the democratization of life sciences in space, like avoiding custom pieces of hardware, like I said, using things like 96 well plates, because that means folks from around the world can more easily access life sciences capabilities on ISS and also future platforms. So, yeah, even in the last 5 years, I've seen a dramatic growth and investment in this area from around the world.
Sam, I think we have another question in the back. Thank you, Dr. Sharma. Great response.
Let's see. Quick question on is one of the markers the hypoxic induced factor? Is that being used as kind of a baseline in any of this? And then another question, kind of in that realm, many people talk about the hyperproliferation, and I wonder, is there a good marker that's been identified, because it's not very quantified at this point. I just wonder if there's also a marker that's going to be used to identify hyperproliferation. And then I want to move on to another kind of area, which is in VAST and Starlabs. It seems like there were just so many considerations of the kind of work area, and that the work area has to do kind of life science and semiconductor, plant biology and everything. So you hinted at the idea of just, say one GMP facility, kind of thing. And also, and what came out in your presentation is just the difference between the automated that's, being done by Bioserve and Space Tango versus, this very manual process. And so it's interesting. My question is, how are we, accommodating that in both the Starlabs or the VAST or the other, which I think it's really, not going to happen in such a way that both the very manual and the hyper automated is going to be accommodated. I wonder what your thoughts are on that.
Yeah. So yeah, a lot to unpack there. I'll start with the question about the hypoxia inducible factors. So that's HIF1 alpha, and it's it's not a reporter that we've built into our systems, but we know other folks who have, and it could be a nice visual readout for the health of these stem cells. It's something that we can indeed engineer. We've been looking at the expression of HIF1 alpha more at the transcriptional level. The second question was on the cell proliferation and how you'd be able to track that. It depends on the level of proliferation that you're trying to examine. So, for example, if you're looking at at a cell, like intrinsic cellular level, we can have markers such as Ki67 and other well-established proliferation markers, which again we can engineer into fluorescent reporter lines on these IPSCs. So again, we'd have like a real-time live visual readout of how these cells are actually dividing faster in space. But referring back to the organoid side of things, and I wish I had more time to talk more about that experiment, the results there were so profound that we're looking more at the level of the organoid and the number of those that we were actually able to produce in contrast to the terrestrial ground side controls. So it was literally just automated organoid counting that we did from the images and videos that we obtained on the ISS. So that was because, and again, the results are not always that clear, but in that situation, it was very striking. And then your last question was about the capabilities that are being set up aboard Starlab and Vast Haven. And, again, because we're here in LA, full disclosure, we're just down the road from Vast, and I've had a number of conversations with them about, doing research on Haven. In contrast to the ISS, which has been around for very long, and I think a lot of these research capabilities are pretty well established, advanced microscopy and all that, I think the studies conducted on the new commercial LEO destinations will initially have to be more targeted, right? And so I do think there's still a utility for manual astronaut intervention in a number of these studies, especially some of the more advanced studies. But given the conversations I've had, I think there's going to be a shift more towards the automated approaches, just because it seems like you can get more science done, right, with less crew time. So I think there's a need for both, but my gut feeling is that there's going to be a shift in that direction.
All right. Thank you, Dr. Sharma. We are going to take one more directed question from the audience. This time we are going to go to our digital audience. So the question is from Dr. Aisha Albalushi. Do you see specific cytoskeletal or YAP-TAZ pathway signatures consistently altered across iPSC lines? And could these be targeted to modulate differentiation efficiency in space?
That's a great question. We haven't done really deep cytoskeletal analysis of the iPSCs. We've done some with that initial 2016 mission on the differentiated cardiomyocytes, where we did see some structural changes at the sarcomere, muscle fiber level. But it's not something that we did at the pluripotent stem cell level. And again, it's something that we could do by engineering fluorescent reporter lines. And you're right in that regulating cytoskeleton is a way to regulate differentiation capacity. So yes, it is something that we could definitely explore initially through some simulated approaches, microgravity simulator approaches here on the Earth, but for deeper analyses, it's something that we could do on the ISS.
All right. Thank you so much. Although I feel like this conversation could go on for much longer, I think that tells us we need to have Dr. Sharma back again for a more directed workshop in the future focused on iPSCs in space. However, we are at the end of our time for now. Dr. Sharma will be rejoining us for the panel at the end of today's session, so we will have an opportunity to hear more from him. In the interim, we are going to break for a small intermission. Please feel free to use the restrooms, grab another cup of coffee, a muffin to mingle and talk with your peers, and I will call the room back to order at 10:40 a.m. for us to reconvene. Before we do so, I do want to just really quickly put in a plug as well for, Sam, how do I switch this to... Sorry, I don't know anything about how to run any of the tech side of this. I would be lost without Sam's incredible work. I am going to put in a plug for the remainder of our workshop series. There have been a number of topics that have come up today that have either been addressed in some of our previous workshops or will be addressed in our future workshops. Today's event is event 5 in a 7-part series on bioastronautics, where we dive deeper into a specific subtopic at each of these events. If you missed any of the ones that are on the screen, so exploring human performance, technology development, microbiome and immunology, habitats in space. If you missed any of those, no worries, reach out to our team and we can provide you with a recording of the sessions. We do have 2 more sessions coming up, psychology in space and advancements in space training in the near future as well. And we would love to see everyone who's here at those events as well. So you're all invited. Feel free to share that invitation. This is an all are welcome event series. So one more thing that I will mention about those is a couple of times during our presentation so far, both from Dr. Mayuga and Dr. Sharma, we've heard the term implementation partner, and we've heard a couple specific partners called out: Space Tango, Bioserve. Both Space Tango and Bioserve presented at our Technology for Health in Space workshop, and they gave great presentations that really go over both the technology that they utilize to conduct biological sciences in space, but also the process of working with an implementation partner to develop your research for space and operate it in a space environment. So if you're interested in learning more about those, reach out. We will send you the recording of that lecture, and it has a lot of great information about how to really kickstart and get started within space sciences. So now that I've spent that much time talking, we will actually rejoin at 10:45 a.m. Thank you all. And at that point, we will have a keynote from astronaut Tim Kopra. So make sure you come back. Thank you so much. Okay, hello everyone. I'm sorry to interrupt the fantastic conversations that I see happening all around the room, but it is time for us to return back to our program for our keynote speaker. So it is my great privilege to introduce Tim Kopra. A seasoned executive and leader, Tim Kopra is Chief Human Exploration Officer at Voyager Technologies. Previously, Tim served as CEO of Starlab and NanoRacks, a part of Voyager's Space Solutions business segment, as well as president at OneWeb Technologies, vice president of robotics and space operations at MDA, and founder and partner of Blue Bear Capital. Prior to his work in the private sector, Tim spent 18 years as a NASA astronaut. While at NASA, Tim lived and worked on the International Space Station, completing 2 space flights and 3 spacewalks over the span of 8 months. In 2016, Tim served as the ISS commander for Expedition 47. Tim also served in the U.S. Army for 25 years as an Army aviator and experimental test pilot. During his military career, he was deployed to Operations Desert Shield and Storm, commanded an AH-64 attack helicopter company, and served as the developmental test director for the Army's Comanche program until his assignment to NASA. Tim earned his Bachelor of Science from the United States Military Academy, a Master's of Strategic Studies from the U.S. Army War College, a Master of Science in Aerospace Engineering from Georgia Tech, and master's degrees in business administration from both Columbia Business School and the London Business School. And in addition to all of Tim's really impressive professional accomplishments and accolades, I'd like to say just a small personal anecdote as well, which is that Tim is one of those unique people who really invests and is generous with his time for the next generation. So as an early career scientist myself, I've been grateful for Tim's mentorship, and I know that there are many others out there in the world who are grateful that Tim believes in planting the seeds for the next generation of space exploration. So Tim, we're thrilled and grateful to have you here with us today.
Thank you, Abby. Thank you, Abby, for the very kind introduction. And it's really great to be here today. I was talking with Dr. Mayuga just a few minutes ago, and he said, it's strange to be talking about astronauts in front of an astronaut. And I said, well, it's strange to be talking about medicine and human performance among a bunch of doctors and researchers. So it goes both ways. I thought that it's really important for this audience to 2 things. One, understand where have we come from with the International Space Station, and what does the future look like? Because as we know, the International Space Station will be retired, and there's a super bright future when it comes to this next generation of research and development in low Earth orbit. International Space Station, as Abby mentioned, I had the great fortune to spend 8 months on board over 2 missions. One of the most incredible engineering feats, perhaps the most incredible engineering feat in modern times. And it was built over, as I think people know, over 40 space shuttle flights assembled in space, which is massively complex. When I was on STS-127 on Space Shuttle Endeavour, we brought up the Japanese exposed facility. And just that one mission took 3 robotic arms, 2 spacewalks, and all of the ground testing to make sure that the design matched the build. And at the end of the day, we come up with this laboratory in space that's equivalent of about a 5-bedroom house. It generates power, rejects heat, has life support systems on board, the motion control, attitude control, really an incredible feat of engineering. And what it's evolved to over time, and it really has been an evolution. It didn't really start out as a really distinct purpose as a U.S. laboratory, but it certainly is today. And, you know, one of the areas I thought was really fascinating in terms of NASA's response to identifying a problem and then responding to it was the issue with crew members' eyes. There's been a problem that I guess has been part of the space program from the very start, but became much more prominent and understood that the interocular pressure would increase. And so what NASA did in response was develop what is essentially an ophthalmology clinic on board, an optical coherence tomography device, a fundoscope to take pictures of the blood vessels, the optic nerve. And then what that's resulted in is really understanding this phenomena as we go forward. And hopefully we can find solutions for this, because there's actually a really interesting corollary to this when it comes to glaucoma. In fact, there's a company called Balanced Ophthalmics that has a durable medical device that pulls a small vacuum on the eyes and actually reduces the pressure. There may be an exact opposite solution, but using the same medical device to add a little bit of pressure, that could be a prophylactic solution for this SANS phenomena. And then the rest of the laboratory on board on the right-hand side, you can see a glove box, which is important to isolate certain experiments. But really, it's a full-up laboratory in low Earth orbit for those things that can only be done in a zero-gravity environment. One of the earlier talks mentioned the fact that it's very necessary for crew members to exercise in space. In fact, if the crew didn't exercise and put that load on the body, they would lose about 2% of their bone density per month. So it's a very critical aspect of the crew day, about 2 hours a day, and 3 different exercise devices, an ergometer, a treadmill, and a really interesting piece of hardware called the Advanced Resistive Exercise Device that pulls against 2 vacuum cylinders. It feels just like doing a deadlift, bench press, squats. And as a consequence, at least for me, I can speak personally, within 2 weeks of coming back, the things that they measure in terms of balance, strength, and agility, all those things were about at baseline. Still tired for about 6 months, which, you know, could be a lot of different factors, but it's a great countermeasure to this effect of zero gravity. And at the end of the day, the crew members are part of the experiment. In fact, one of the main experiments, understanding the effects of zero gravity on the human body. This is my colleague and good friend, Tim Peake, you know, drawing blood, but we draw blood, we collect our urine, you know, saliva. In the background is an ultrasound device. And as you can see, this is a really good picture to demonstrate that there really is an evolution of this space station over time. It's frankly very cluttered, and it's really a testament to that we've learned so much in terms of how do you organize a space station with limited volume. And frankly, these are great lessons learned as we go to this next step of space stations in the future. 2 of the most physiologically challenging aspects of human spaceflight is launching and landing. When I launched on the Russian Soyuz as the co-pilot at a Baikonur Cosmodrome back in 2015, you know, 8.5 minutes you're in space. And physiologically, it feels very similar to launching on a space shuttle. And then what we've evolved to now, instead of back in the day with the space shuttle taking 3 days to get to the space station, we do it in about 6 hours. So 4 90-minute laps around the planet, increase in the orbit to make it match. But you experience zero gravity after 8.5 minutes. So what's really fascinating from a personal perspective is, in this case, waking up in quarantine in Baikonur Cosmodrome and then going to sleep on the International Space Station just a few hours later. So coming home, I started this conversation with a few folks beforehand. Coming home from a space shuttle, you land very gentlemanly and it's a nice smooth ride. When you come home on a Russian Soyuz, there's a whole series of events that are fairly dramatic. You undock from the International Space Station about 45 minutes to drift away. Then a whole series of events happen where you separate the living compartment on top, and then you come in at about 5.5 Gs. You can see the plasma burning past the windows. The chutes deploy, and a good friend of mine, Doug Wheelock, who actually spends a lot of time here in Ohio, told me before I flew on the Soyuz, he says, if you're not strapped down, you might just die. So you're always strapping down until you're really firmly seated in that seat. And I really respect Russian engineering because it always falls in the category of just good enough. So you have a seat liner, and the seat liner is made exactly to your form. And the way that they make that seat liner is you sit in a big metal bathtub that has a seat liner in it. You're wearing essentially long underwear. They pour a bucket of plaster around you. You hop out, they shave off all the sharp places, put cloth on it, and then that's your seat liner. And then when you come back in, the seat cocks up just a little bit so that you're about 6 inches away from the screen. So you have a damper that is able to absorb some of that shock. But, and there's also soft landing jets that activate just about 200 milliseconds before impact. There's nothing soft about the soft landing jets because you hit so hard that you probably spent about 10 seconds doing this personal inventory to make sure that nothing is broken, but it turns out that it's just good enough. And then they pull you out of this small module like a breech berth, and a very Russian strange phenomena is you have a press conference in the middle of the desert right off after you came off of this little spaceship. You can see how burned up it is when it came in. When I came home the first time, in fact, there was a bit of a difference between the first and the second time. Second time was less severe, but the first time in particular, for about 2 days, it felt like a combination of the flu and a hangover. Because all those systems that your body accommodated to that tell you about which way is up, they get completely turned off. And there's this process. It's a few days where you think you're pretty comfortable, a couple of weeks where you think you're fully adjusted to zero gravity. But after about 6 weeks, you can flip around and your brain is doing this matrix transformation to tell you which way you're oriented, and it feels completely natural, which is strange in itself. What that means is that your neurovestibular system has adapted, your proprioceptive system, your eyes, what you see and what you feel. But when you come back home, all those different systems have to get reoriented, and it's quite the challenge. We talked about orthostatic intolerance before. What the Russians have designed is this set of clothing called a centaur, where you strap it around your calves, thighs, and lower torso to push the fluid back up. And I remember coming home from the second flight, and we stopped in Norway, and I had to go to the restroom and took off my centaur and almost instantly passed out because it was just an exaggerated orthostatic intolerance. So International Space Station has served an amazing lifetime. It was designed for a 15-year life, and here it is. The plan is for it to go to 30 years, but it's going to go away. It's going to get deorbited and put into the Pacific Ocean. And even though that it feels it's going to be a really sad day for all of us that spent so much time with it, both from the ground crews and the astronauts that have flown on board, it's time to retire it. A lot of the crew spends an increasing amount of their time doing maintenance on board. The supply chain for the different components has started to really wane. And it's a really expensive vehicle, about $6 billion a year, about 4.5 of that coming from NASA for all of those different operations. But even from that, there's been an amazing number of patents that have been developed over time. And on both of my flights, there's always about 250 experiments that are ongoing, and a variety pack. Some require lots of crew intervention. Some are very automated. And I think that'd be a great panel discussion about the transition of autonomy and shared autonomy. So here's our view of this next evolution of space stations. I mentioned that International Space Station took over 40 space shuttle launches, not including all the different Russian launches to assemble that space station. a very complex operation. And so our solution in turn is to not have to do that. A single launch to orbit that has about 2/3 of the volume of the US portion of the International Space Station, but with all the R&D capacity, which is really important. So what that in turn means is we can have a continuous human presence in space from the very start. A crew of 4 that's there for 6 months at a time, a second crew that comes up for about 7 to 10 days for a direct handover, which in turn means that our life support system sustains 8 people. So during that 6-month mission, we can have an additional crew of 4 come up for 2 to 5 weeks at a time. And that could be some of the countries that want to participate in space, because there's been a really amazing growth of space agencies around the planet. 2 decades ago, there were 50 space agencies. Now there's 80, and it continues to grow. It could be principal investigators. It could be spaceflight participants, which we think is a very small segment, but it accommodates that entire ecosystem of people that need access to space. And what we've chosen to do is build an international partnership. Instead of a partnership like the ISS with countries, we've selected the best-in-class companies. Voyager, that has the Bishop airlock on board the International Space Station, launched about 330 satellites, about 1,300 payloads that have gone to the International Space Station. Airbus, that designed and built and now helps to maintain the Columbus module on board the ISS. Mitsubishi through MHI, 3 of the elements on board the ISS today. MDA Space, where I served as the Vice President of Robotics and Space Operations. No one does space robotics better than them. Space Application Services, not listed here, is also a European company that's a partner of ours now. It's essentially like the Voyager of Europe when it comes to payloads. Northrop Grumman joined us as part of this commercial low Earth orbit destination program. And so we took over their funding, but they're also designing and building an automated docking system for their Cygnus resupply vehicle. And Hilton is a great partner from the standpoint of making sure that we have a very ergonomically designed and an efficient space station. Also not listed here is a company called Journey, which is the architectural firm and designer that designed the Sphere in Las Vegas, and an amazing combination of that architectural skill and also the aesthetics and ergonomics so that we can be hyper efficient. And then last to mention, Palantir has been an amazing contributor already, because even though the operations on board the ISS are truly amazing, it's done with thousands of people, which is not really economical. And so what Palantir has showed us, how we can be hyper efficient when it comes to logistics, monitoring the experiments on board, the efficiency of crew time, and then building a digital twin so that we can do very responsive and conditional maintenance on board. So the way the station is designed is taking advantage of this massive volume with about 130 mid-deck locker equivalents. A mid-deck locker has its legacy from the space shuttle. You had the flight deck and you had the mid-deck, and the mid-deck had lockers, and it's become a standard size. So 130 mid-deck locker equivalents. And the way the station is organized, about half of it is the laboratory equipment that we know that we need on a space station, because we've been doing this with the ISS for 26 years, and we know what's really valuable equipment on board. And then the other half is available space that we can lease out to other companies, academic institutions, or government agencies, and we're about 90% sold out at this time. So on the previous picture, you see, let me go back one for a second. You see at the lower half, you have 3 decks. There's actually a deck at the very bottom that's used for stowage, more of a crawl space. The cone on top is really used for stowage and a lot of the external equipment that's attached to it, and a docking port on the top. But then the primary living space are on these 3 decks. You can think of this as essentially like a very large 3-story condominium. And in the context of like a large infrastructure, the bottom floor has all the equipment you need to operate it. So the bottom floor deck, or level 1 on the left-hand side, has the life support equipment, avionics and software, but also the hygiene station, exercise equipment. And then deck 2, level 2, is where the heart of all the experiments and the operations occurs. So the crew during their workday will spend predominantly their time on that second level. And then deck 3 is where the crew lives. And that's what's great about having both Hilton and Journey as part of the team, because you can make this a really great place to live. Individual crew quarters for up to 8 crew on board, a galley table, the windows, and additional research and development capacity on board that level. So one of the advantages of taking the lessons learned from the 26 years of the operations of the International Space Station is what is done very well and what are the things that we can improve. So stowage is always an issue on board the ISS. And what that does is impact the efficiency of the crew when they're doing their experiments. One example is Tim Peake and I were working on an experiment to understand the effects of zero gravity on bone loss with mice. So we had 20 mice and we're working through this experiment, but it took an entire day to set up this experiment with the glove box because of all the different equipment that was required to set it up. And it's like living in a house with a bunch of very small rooms, and those other small rooms have all of that ancillary equipment. So you're going to the PMM and the JLP and the JPM, all these different modules on board the ISS to collect that hardware that's required. Whereas when you have a large volume like Starlab, what that in turn means is you can be very thoughtful about where do you locate all of this equipment and be very efficient with the crew time. NASA estimates that crew time on board the ISS is about $135,000 per hour. So it's expensive. Ours will be a fraction of that, but it emphasizes the point that for a revenue generating space station, you need to be very efficient in terms of how do you organize the crew day. And then in terms of exercise, we're working with a Danish aerospace company for this device called E4D that gives us the capacity in one device to do both the strength, conditioning, an ergometer, rowing machine. And so this will be really useful in terms of an efficient use of space. And we're also looking at other ways that we can have exercise on board Starlab in the future. In fact, this piece of exercise equipment is going to the ISS. So it's a great proof point to make sure that we have the right piece of hardware and protocol when we have Starlab coming up here shortly. So the purpose of a space station, in our view, is to meet the exploration objectives of NASA, but also other space agencies, ESA, JAXA, CSA, UAE Space Agency, and others. But then also, we're in this transition of commercialization. And what I think is really amazing is even since my last flight in 2016, there's been these really incredible developments. It's been this evolutionary process of understanding what can you do in a zero-G environment. The early experiments on board the ISS were a bit of square peg, round hole. We have this facility. How do we make it work? And it slowly evolved into something that we see as proof points what the future of commercialization looks like. Some of my favorite examples, Merck took one of their billion-dollar cancer drugs called Keytruda, and they're able to make the fundamental protein crystal in mass. So what does that mean? It means that it can change the delivery mechanism, the side effects, but it could also extend the patent. And it's a $1.1 trillion industry that puts 15% of its profits back into R&D every year. Some other areas we won't talk about today, since this is really focused on human performance and medicine, but very interested in material science and semiconductor crystals. But on the life sciences part, frankly, to me, it sounds like science fiction that the crew on board bioprinted a human knee meniscus and vascularized it. A company, Lambda Vision, that's on board ISS today that's bioprinting retinas. So this is a great thing from a commercial perspective, but also solving amazing problems that exist on Earth that we can help to solve on board Starlab in the future. So takeaways here, ISS is going away, and we're very excited about what Starlab will do to meet the exploration objectives of space agencies and take advantage of those proof points on the ISS that we can commercialize in the future. And the single launch to orbit concept and now design that we're building is super important. If you don't do it that way, what that in turn means is it'll take a period of years until you have the capacity to really have the type of research that's needed. But also from a business perspective, you really can't have a business plan if you only have 10 mid-deck lockers to start out. So from the very start, we can have a crew of 4 on board that can begin those different operations. And what this in turn means is that we can leverage the capabilities that have been demonstrated on board the ISS today, and then really take that to the next level. From a business perspective, it also gives us the opportunity to generate revenue. And one of NASA's objectives is to offload all of the expenses that are associated with human spaceflight. And that's really precisely what our plan is. And we've already seen demand signals for a second and a third Starlab. When you design a single launch to orbit space station, once that's complete, the non-recurring engineering is done. The ground systems are in place. We'll have perfected the assembly, integration, and test. So we're excited not just about Starlab 1, but about Starlab 2 and 3 in the future. So with that, I'd be happy to take some questions.
Okay, thank you so much, Tim. We do have time for a couple of directed questions for Tim. So feel free to just pop your hand up and we'll get you a microphone, or to drop your question in the chat if you're joining us virtually. Hopefully you'll all excuse us that I'll also be setting up chairs on the stage for the panel while doing that. So we'll do a little bit of multitasking here. Thank you.
Yeah, so I'll repeat the question. That is, from the circadian rhythm perspective and the lighting on board the ISS, there's been lots of studies that NASA has done when it comes to the effect of light with sleep. And we are very conscious about this. In fact, we have very detailed conversations with Journey about what's required to really optimize circadian rhythm, but also sleep. And for me, I could tell very distinctly the effect of blue light. In fact, if I went, before I went to bed at night and took pictures through the window, which is an amazing opportunity of our beautiful planet, if it was a day pass, it was like drinking 2 cups of coffee and I couldn't sleep. And so I ended up taking lots of photographs of cities at night because I'd have time before bed, and that made a lot more sense. So lighting definitely has an effect, and we're looking at that entire day in terms of what lighting looks like. In the crew quarters at Kennedy Space Center, they're very conscious of the lighting, because back in the day with space shuttle flights, the time of launch could be very different. It could be early in the morning or late at night. And so the crew would spend time in crew quarters with very specific lighting to try to make that shift and just help that out. And I think it had a very positive effect. But the short answer is we're very conscious of lighting on board Starlab because it has very direct physiological impacts. Yes, sir.
Hi, I'm Wolfgang Windel. I run the Center of Excellence for Materials in Space here at OSU. Since you had crystal growth on your last slide, and ever since I saw on Tiangong, they have a really nice dedicated crystal growth facility. Are you going to have something like this on Starlab? I know it's is there a plan to have like a dedicated crystal growth facility?
Yeah, so the question was about crystal growth. We think that the 4 different categories of commercialization that are most important: material science and semiconductors, which have direct correlation to crystal growth, is extremely important. So we do intend to have that as a dedicated facility. Yes, sir, in the back.
I was a green chaser. What? And I see that vast. It's a lot of one of the big things that our lab is doing to kind of get these prototypes tested.
I think your question is around prototypes of hardware.
Just the whole, yeah, the whole ISS replacement. How do we know that components? How are they being tested? You know.
Yeah.
And that's what they ask. You know, they've got that full panel that extends and then it goes and it's so yeah, just as
I understand your question.
yeah, so that would be from the investment side, from our side.
Yeah, the question is around, frankly, design and build philosophy of Starlab. So I'll address it that way. So here is our view. If you're SpaceX and your plan is to launch hundreds of rockets, it makes perfect sense to vertically integrate. It took them 12 years to vertically integrate, but it makes sense to vertically integrate. If you're building a single space station and then plans for a second and third, if you look at the supply chain for all of the different subsystems, the supply chain is actually quite mature. We know who to go to build the primary structure, to provide our solar arrays, our control motion gyros, our life support systems. So we're at a place in the evolution of space technology where, in our view, if the primary business model for a Starlab is to provide an orbiting laboratory and facility, then it makes perfect sense to take advantage of flight-proven hardware instead of starting from scratch. You know, having spent 8 months on board the space station, what's really important is you have a safe crew. And what makes a safe crew is having safe hardware. And what safe hardware is ones that have flight heritage. So we would say that we don't agree with the premise that you start from scratch and vertically integrate for a supply chain that already has mature capabilities, that already has time and space, and it's really a version 10, 11, 12 that you're purchasing and procuring. So what that in turn means is, from a business perspective, the challenge is having the right design and then making sure that you select the best-in-class suppliers. And then from a procurement perspective, ensure that they're on time, on cost, and on quality, and then assembly, integration, and test. So it's a different business model, but we think it's one that is much safer and will be more reliable in the long run.
All right, thank you so much, Tim, and thank you to everyone in the audience for these really great questions. We are going to take one more directed question for Tim before we move into our panel and full audience Q&A period. This time, the question will be from our virtual audience. So on behalf of Simon Ebbets at Nowtex Global, who will train and prepare the Starlab crew, both pre-mission and then also provide rehab post-mission?
Yeah, so what's interesting about this new model that NASA has endorsed of commercial low Earth orbit destinations, this is very similar. The longer answer to the question is, this is similar to what NASA chose to do when the space shuttle was retired. They started the commercial resupply program and commercial crew program. Commercial resupply with SpaceX and Orbital Sciences, and then Orbital Sciences was merged and sold off to Northrop Grumman for $8 billion. So they allocated $1.6 billion to SpaceX, $1.9 billion to Orbital Sciences at the time. Very similar for commercial crew with SpaceX and Boeing. And the reason NASA did that was because they recognized that there was enough maturity in terms of technology and operations to transfer that to the commercial sector with lots of government support financially. So truly a public-private partnership. The same is true for space stations. So when NASA, as an anchor customer, provides, say, a couple of their astronauts for a 4-person crew, Starlab owns the entire value chain of getting that crew to space. We train them, we fly them to Starlab, they work on board that meet the exploration objectives of the agencies, but also the commercial work. we bring them home safely, they go to quarantine. And so when NASA and the other agencies write us a check, just like they do to SpaceX and Northrop Grumman today for cargo, or SpaceX and in the future for Starliner, they own that responsibility. And so we own that entire ecosystem for the crew.
Fantastic. Okay, thank you so much, Tim. We'll have one more round of applause for Tim. Thank you. And then I would like to invite Dr. Mayuga and Tim to take a seat on the stage, and we will get Dr. Sharma back on the big screen as well and move into our panel and larger audience Q&A. We're going to start out with a couple of questions that we've pre-prepared, and then we will move into questions from the audience, both in person and online. So start percolating on those and thinking about what you'd like to ask. All right. Okay. So it looks like we are all back together. Thank you, all three of you, for fantastic presentations today. Really appreciate you sharing your expertise with us. And I want to point out what an opportunity it has been to have perspective from three different directions on spaceflight. So looking at the clinical practitioner side of things, looking at the academic research side of things, and then of course, looking at actual flight experience and significant experience in the business side of commercial space. So thank you for all of those. And that really leads me to my first question, which is, when you look at the future of spaceflight and particularly consider this really unique transition period that we're in right now, moving towards commercial providers in low Earth orbit, what do the three of you see as the largest, I suppose you could say, pain points that we need to solve for space medicine? How do we make these conditions better for astronauts in the future when we're in this interim period of change where we really have the opportunity to change how things are done?
It's a great question, Abby. In terms of the things I talked about in my presentation, one of the main questions is what's going to happen with people who are not as selected as the fantastic Tim Kopra here. And so, what kind of health challenges will those individuals experience when things get a little bit more proliferated, and that's going to be a challenge that we should meet, because this is only going in one direction and it's just expanding further. So lots to think about there. Great question.
Dr. Sharma, you want to go first?
Yeah, sure. I can jump in. Pain points for me from the research side and academic research side is ensuring that the capabilities that and discoveries we've made on the ISS continue without a gap into the CLD era. I think we're really at the cusp of some amazing translational applications for, say, stem cell manufacturing, protein crystallization, that sort of thing. And I want to make sure that the work is able to seamlessly transition into the new CLD era, perhaps with, free flyers serving as a bit of a stopgap before things are really concretely online towards the end of the decade. So, that's the thing that seems most critical to me.
A few thoughts. I think that there will be a broader spectrum of astronauts when it comes to the medical qualifications, but it's also important to recognize that mission success correlates to successful business. So I think that there still needs to be a pretty rigorous process to make sure that so that you're not going to anticipate any sort of medical issue. We just had a circumstance recently, the first time in 26 years, that the crews had to come home for a medical issue, which, it's unfortunate that had to happen. But if you think about it in the perspective of 26 years, it's the only time. I think that goes to the rigor by which they've made sure that the crew members that go to ISS are in a physical condition that allows for that mission success. A couple other areas that I think are intriguing. When it comes to the medicines you have on board, logistically, there's like these packets of that take up so much volume because apparently, and I think this audience would know better, that radiation degrades the quality of the medicines over time. But logistically, it's a huge deal. And if we're going to go to Moon and eventually to Mars, we have to find a better solution because flying up these big packets of every conceivable medicine every 6 months is not really sustainable if we're going to go much deeper. And then I wanted to touch on one topic that you had mentioned before, Dr. Sharma, about automation, which I think is super important. But one thing that was evident during my time on board the ISS is that there's ways to really optimize the equation when it comes to shared autonomy. There's some things that can be automated that makes perfect sense. Full automation, I think, is a great objective, but it also means greater mass, complexity, chances for failure. And so finding that right compromise as we evolve to full autonomy for shared autonomy is, I think, one area that we should really investigate.
Fantastic. Thank you, all three of you, for those thoughts. And one thing I will mention, Tim, is that I heard you loud and clear when you mentioned that a great future workshop or panel discussion would be around that mixed use autonomy versus shared autonomy. And I will make a point to talk to the workshop organizers about possibly getting that in our next series. So our next question that I will ask is, when we think about spaceflight, we think about producing value for Earth through a number of different ways. We can either produce information and material benefit in space, or we can produce resources for space that then have spin-off applications that improve life here on Earth. Specifically, when you think about space medicine, which is often described as medicine in an extreme environment, one of the most extreme environments that we know, space. What types of terrestrial applications or spin-offs do you see there that could impact the greater population through this investment in continued space medicine research?
Fantastic question, Abby. And I think I can point to one of Tim's points from his lecture. With this SANS, space-associated neuroocular syndrome, it's a problem, and it seems like there's a potential way of treating it with this sort of positive pressure type of phenomenon, and so that has a direct application into other diseases here that terrestrial and the terrestrial population experiences. Orthostasis, for example. With orthostatic hypotension, with transitioning from microgravity to gravity, what lessons can be learned there in terms of is that type of Russian I forget, it starts with a K. Yeah, that type of compression. Is that going to be useful for patients with orthostasis here on Earth? It sounds like it's a little bit bulky and things like that. But in terms of how can that be adapted or utilized, to address the huge population of patients here on Earth who have orthostatic intolerance. Those types of things can be translated directly or with the knowledge gained in developing these systems for space flight, it can have direct implications. So that's why I think it's so fascinating about this whole type of endeavor, and that's what spurred us to make this Space Health Center at Cleveland Clinic within the past year. So we're very excited.
Yeah, I could jump in to answer part of that. In terms of therapeutic applications, the things that excite me the most are potential cell therapies or bioengineered constructs that can be made in microgravity at a superior way that could ultimately be used for downstream clinical or translational applications. So, the examples have come up already a bit during this meeting, like, for example, bioprinting of thick tissue constructs that are potentially vascularized. And terrestrially, there's a lot of applications here for cellular replacement therapy, whether it's for cardiac tissue, whether it's for liver tissue. Similarly, if we're able to show enhanced production of organoids and stem cell derived products in space, not only could those directly be used for clinical applications, but as we know terrestrially, using organoids for drug discovery is a multi-billion-dollar market. So, there's in vitro and in vivo applications for the things that we're able to make in space.
As the non-medical person here, although I did serve as the chief medical officer, which is such a stretch for a test pilot to do that, but that was still fun. The idea of being able to bioprint human tissue and learn from that, but also provide a capability, and from a business perspective, something that has tremendous value, it's very lightweight, also makes lots of sense.
Absolutely, very interesting. And that leads me to a question that I would like to ask on behalf of one of our virtual audience members, Dr. Albelushi, who is wondering, what do you envision as the regulatory pathways for space manufactured stem cell products, especially within the FDA GMP requirements, if production is occurring primarily or partially in orbit? And I would expand that question, if you'll allow me, Dr. Albelushi, to say not just stem cells, but other biomanufactured components within space as well. What type of regulatory concerns do we need to take into consideration there?
That is a lawyer question. and it's a broad one too, right? Because sometimes technology is a limiting factor. Other times it's regulatory and legal structure. So I think that at the same time as we're going through design, build, operations, when it comes to making sure that we can really take advantage of the zero gravity environment, there's a whole nother category that has to be really it's a trailblazer effort because it's so new. Perhaps my colleagues here can better answer it.
Yeah, sure. I think engaging early with the regulatory agencies, with the FDA, even in the basic research steps, is really important. It's something that we've done already, but I'd like to think we have a bit of a leg up in that we have an on-campus biomanufacturing facility that has had a lot of these conversations already. I mean, they're making terrestrial cell therapy products for direct use clinically in our hospital. So it would be an extension of the work that we're already doing, but of course, a lot of unique caveats.
I'm going to defer that question, if I may. Thank you.
Great answers from both perspectives. And I definitely agree both with that concept of get in early and start talking with the FDA in those initial stages of your research, as well as I also agree with pass it off to the lawyers. I would wonder if we could add in there as well that when we think about biomanufacturing in space, that is one area in which automation does become not just important, but nearly a necessity to ensure quality and to ensure safe practices within a space manufacturing environment. Something that we'll have to add to the agenda for our next workshop in automation next year. At this point, I would like to open it up to our audience members, both online for further questions and in person. So please feel free to pop your hand up if you have a question, and my colleague Sam will run a mic out to you.
Hello, my name is Maria DeVita. I'm a biomedical engineer with a specialization in medical product development at OSU. Where do you see the biggest gaps in medical device technology, whether that's preventative intervention, diagnostic, or treatment?
I don't have a good answer for gaps in medical devices. What I think is intriguing is the ability for all of us to measure, our activity with our Apple Watches or other devices and be able to integrate all that, and take, I think one of the examples you provided, Dr. Sharma, was taking off-the-shelf hardware. I think that's super important. There was a NASA award that was offered a few years ago for the best innovation in software that was developed by NASA. I think a much better solution would be the best application of commercial off-the-shelf software that was used in application of space. I think the same is true for durable medical devices. If we can adapt what's in the marketplace and solves a problem or gives us more insight, on board the ISS and then eventually Starlab. I think that's a much better solution. I am intrigued by what Balance Ophthalmics is doing to treat glaucoma and potential that has to take care of SANS prophylactically with crew. There may be other examples that my colleagues here could answer.
Also, a very, very good question. One of the discussions I had with the folks at NASA Glenn Research Center was you can't take everything with you. And so one of the challenges is to decide, with the space that you have, how can you be most efficient at bringing diagnostic equipment, for example, and trying to predict what kind of medical issues you're going to run into, and trying to predict, well, if you run into that, what's the best way to diagnose it? Is ultrasound that is very manual the way to do it? Is ultrasound that's automated the way to do it? Is ultrasound that's guided by someone here terrestrially the way to do it? Is AI going to be involved? Those types of questions are current questions that even just on the diagnostic side is a challenge in terms of space limitations. And on the therapeutic side, what happens if you need to do a surgery in space? And are there ways to do that in an automated way? Are there ways to do that in remote surgery? Ways. Do you need a specialist on terrestrially to manage things on the space station, or even in other situations? So those are types of questions that are being looked at, but are good challenges. And you're in a fantastic field, and look forward to seeing what you can do.
Yeah, I think it's a really great question. One thing I'd like to emphasize, and this is something that my colleagues were emphasizing as well, is further fleshing out our capabilities for real-time and remote analytical capabilities, right? And it goes beyond Apple Watches and standard smartwatches and so on. I think that's been great, and I think the form profile has been really good for those as well. But extending that onto the research side of things, I think part of the reason that we've been able to be so successful with our research results on ISS is because we've had real-time ways to analyze, say, cell growth or organoid manufacturing, whether it's building in fluorescent imaging reporters into the cells that allows us to longitudinally image the cells on the microscopes on the ISS, because more data is better, in my opinion. Like, we don't want to wait for results to come back after samples or astronauts come back to the planet. We want to be able to do those real-time analyses longitudinally at the time of the experiment. So, further developing out those capabilities is really important.
One additional thought when it comes, you mentioned ultrasounds, that the crew becomes quite adept at doing either ultrasounds on themselves or ultrasounds on their colleagues on board, and also in conjunction with a principal investigator that can help to guide. So there's a role for the crew to be involved in making sure that they can collect that kind of research. I think someday we'll have the Star Trek scanner and you just run it over your body, or you just go into some tunnel and it tells you everything you need to know about your physiology. But there's a role for the human to be involved there, and it goes back to your point, Dr. Sharma, of having that real-time feedback for data.
I'm so glad that this conversation has involved so much talk around ultrasounds, because I think that when we think about this concept of solving for space to solve for Earth, and how we can find terrestrial applications for our spaceflight generated technologies, ultrasound is an incredible example of how that has impacted people here on Earth. The ability to use ultrasounds in remote regions, in rural areas, to bring that to, for example, pregnant women and provide regular screenings was not available to the extent that it is now prior to the ISS. And it was really the need to create ultrasound machines that were smaller, used less power, and were more operationally usable by non-experts or people in regions and facilities that are not ideal for medical care. And so I think that that's made a huge impact in medical technology on Earth and in space. And hopefully we'll continue to see that type of development with space technologies. Do we have any other questions? I feel like I saw a couple hands right over there. Perfect.
Hi, thank you for coming and bringing your expertise today. My name is Eliza, and I am studying chemical engineering and biomolecular engineering and space studies. My question is today, as you have mentioned several different times, that astronauts are highly trained people who have been selected from a rigorous program. And as we transition away from our militarized astronauts, who do you consider to be the optimal human being for spaceflight as we transition into this commercial era of space workers and travelers? And who will be making those decisions to find the best humans for this type of spaceflight?
It's a good question. So the astronaut corps is about half military and half civilian. And the military folks in the office typically are stronger on the operational side and less on the technical. And then on the civilian side, much stronger on the technical and less on the operational. So it's actually a great partnership to have both. I wouldn't say that it's militarized at all. I think it's taking the expertise from the military service, because there's lots of like hands-on experience. And if you look at the original 7 astronauts, all military test pilots, which is a really great place to start a space program, because the role of the test pilot, which is my personal background, is combining the operators who don't fully understand the engineering and the engineers who don't fully understand the operators. So melding those two together, because human spaceflight is this very unique connection between technology and being able to operate it. And that's what, NASA in particular has done so well through the entire ecosystem of people, from the engineers to flight controllers, flight directors, and the crew. So there's a really good combination of all that. In the future, if you look at the expense of putting humans to space, it's going to be a public-private partnership for a very long time in our assessment. That's the reason that the primary customers for Starlab will be professional sovereign nation astronauts, which will be selected by those agencies that go through their own process. It doesn't mean that we couldn't find some very wealthy individual or a Merck or a Eli Lilly or someone who wanted to have their astronaut go on board. That's certainly available in the context of having a commercial space station. But there should be a rigor around that, because you really don't want to have to curtail a mission as a consequence of some sort of medical event. But I think things will be remarkably the same going forward in this commercial world.
Always be this high level of for example, with the health issue.
The question is around experience versus age. I think that's part of the question. I was on 2 astronaut selection committees, once in 2013 and once in 2017. So I've been on the receiving end and then on the selecting end. And, the ideal candidate, because you're dealing with so many complexities and levels of uncertainty, you can train, but at the end of the day, things can occur that require both the experience of the training and the experience of the individual who got to that place of being trained. The ideal candidate for an astronaut is a 22-year-old who is a military jet pilot, PhD, medical doctor with 10 years experience. So there's always going to be this compromise between age and experience. And you see that in the breadth of age and experience within each astronaut class. Megan McCarthy in our class was 28 years old. Kevin Ford was 42 years old. I was 36 years old. So there's an entire spectrum. And I think NASA and the other agencies look at this from a team perspective. You put together a crew, and the crew as a complement needs to cover all the bases. And you get that through that breadth of experience, and that happens throughout a wide range of ages.
Yeah, and I think that when we're thinking about space medicine as well, from what we've heard from all 3 of our speakers today, That's part of what we're doing when looking at the human condition in space, is looking at how can we ensure that we can have the right people in space, regardless of the physiological difficulties that may impose on bodies that are, at different stages of life and whatnot. So as we look at how to protect humans from radiation, that will allow us to have astronauts who are able to fly more missions because they are under a lower radiation load for each mission, and thereby bring additional skill, capability, and history background with them. So I would you guys agree that that's part of what we do in space medicine, is try to figure out how we can get the right people in space at the right times?
It's definitely part of it.
Yeah.
I agree. And thinking about those risks and what, would potentially limit people, and trying to adapt and trying to compensate and try to help, that's part of what we should be doing as well.
Okay, so I'm going to go ahead and ask another question, take this in a little bit of a different direction, but I think it's a big picture question that a lot of us could benefit from hearing, which is, how can academic institutions better position themselves to contribute meaningfully and have opportunity within space medicine research, and especially as we look towards this new era of commercial low Earth orbit providers? I think we have a great perspective here, both from, of course, Tim, Dr. Sharma, and Dr. Mayuga, who have had considerable success and experience with operating as academics and clinicians within the ISS era.
So, for my perspective, as I mentioned previously, we are very new, within 1 year of doing this. And the way we've gone about it, so far at least, has been just try to immerse ourselves in terms of meeting people who are very experienced at, again, I mentioned NASA Glenn and other institutions, and this fantastic group here, the workshops that they've had, the people that they've had speaking, just has really opened my eyes to try to think about how we can help, how we can be involved, and has been kind of a way for us to not only get connected, but also to try to think about where we can contribute. So just being involved in workshops like this, and just being as aware as possible of what's around, I think that's how we're trying to do it.
Yeah, I mean, I think we should continue to leverage what we do best as academic centers, which is, of course, provide cutting-edge research, cutting-edge education, and clinical care, right? And like what my colleague was saying, continue to listen to the needs of the community and seeing where we can best fit in. From our perspective as a major academic center in Los Angeles, like I said during my presentation, we're just down the road from VAST, from SpaceX, from a lot of major aerospace partners and companies. And, we do our best to engage with them and see what are their needs when it comes to human health in space, and establish collaborations organically in that way. So, yeah, I think, just listening is very important.
From a research perspective, one of the problems that occurs between academia and NASA is the length of time that it takes to get research on board. So if you're a PhD student and you want to get your PhD in 3 years, if your dissertation topic is reliant on an experiment that goes to ISS, you're probably in trouble. So there has to be a much tighter timeline. And NASA has lots of layers that we believe will be cured with a commercial approach to this, so that in the future, it'd be much better to have a quick response time, so that we can build confidence in the academic institutions to have more research. More research means more funding. And so we could have this virtuous cycle of making sure that we can actually have meaningful research that can be done in the time for a student to get their PhD and have it really demonstrated on board Starlab in the future.
Yeah.
Well, I, for one,
just a
as a current
quick,
PhD student, am happy to hear that response for sure. Dr. Sharma, would you like to add?
Sure. Yeah. Sorry about that. Just a quick follow-up to what was just said. I think even looking beyond commercial LEO destinations like Starlab and Vast Haven, I think given the iterative and rapid nature of the free flyers, I think that's a really promising avenue to take advantage of. And in fact, something that we've already started to do. We actually have a number of payloads that are going to be launched on free flyers, multiple in the next year. And part of it is because the price points are actually really amenable to the research that we're doing. They're quite palatable now. And you're right, we don't have to wait months, years for NASA approval to ultimately get on a launch to the ISS. Now, that goes hand in hand with thinking about automation, ways to miniaturize some of the experiments that we're thinking about doing because scale is a limiting factor. But I think the free flyers are a tremendous resource as well.
Yeah, thank you so much, Dr. Sharma. That's a great addition and something for all of us in the research community to consider when we think about how best to position our research in space to get that optimal output. Do we have any other questions? Yes, Dr. Williams.
Question from a dumb metallurgist. Can we use pluripotent stem cells to cure bone loss in astronauts?
Well, I'll take that. You can create stem cell derived osteoblasts and osteoclasts, bone derived tissues. And indeed, some of those have already been used for clinical trials at different locations around the country and around the world. Perhaps it's a long-term vision, and it's something that I think we need to take a closer look at. Perhaps not in a LEO context, but as we go towards deep space, we'll need to think about ways to do on-site production of tissues after acute injury or so on, or chronic injury. You won't be able to readily ship biological materials to and from Mars, for example, right? One dream is you may be able to bioprint certain replacement tissues on site. So currently, it's a bit of a stretch, and we still have a lot of basic science work to do to make that a reality, but it is certainly a long-term vision.
Yeah, so I think that's a great question from a metallurgist, but still a great question. And great response, Dr. Sharma. Thank you so much. And I think it kind of does connect into another question we've got in our virtual audience here from Joshua, who is asking after how we see the role of future explorers evolving and what we think are some of those biggest both physical and psychological challenges that we still need to solve to make longer duration space flight safe and sustainable in the future. And I think what Dr. Sharma just said there of this idea that the ability to be able to produce these things in space is not just a benefit towards producing for Earth, but it also increases our capabilities in space. And that all of these questions and problems that we've been talking about today are the problems that we really do need to solve. We need to figure out how to keep astronauts healthier in space for longer. We need to figure out how to keep medicines from deteriorating. We need to figure out how to have autonomous or semi-autonomous response to emergencies, maybe when you are not within a time span that you can return to Earth if you have a medical emergency. So we have a lot of big questions. What do you guys think are about that future perspective?
You've answered the question at the top level, and that is that it's great. There has to be a fundamental change in being independent. So it goes into autonomy. It means that you need to have the ability to create drugs so you don't have to fly them up. You need to be able to use in situ resource utilization on the moon. You need to have communications that are there as a not really a necessary aspect, but something that supplements, which means that the vehicles need to be able to operate autonomously. Which means like very smart systems that can diagnose and, like the entire design has to be focused around a level of simplicity from a maintenance perspective and from a identification of faults so that can be repaired in a rapid way. And then, from a human perspective, you mentioned the psychological aspect. One thing that NASA has done an amazing job on is create an environment for psychological support. When Shannon Lucid flew on on the Mir as part of the shuttle Mir program. She could talk to her family every couple of weeks and had a stack of books that she could read. Whereas when I was on board, even far back in 2016, I talked to my wife every night on internet protocol telephone and had a video conference once a week. So these things are super important. And that's, there's one thing that I think will be super intriguing that day when we go to Mars, which is not soon, but someday, you go around the planet and you're only 250 miles above, but you still get this stark feeling that you're very separate from Earth, because when you go through the light pass, your pupils are very small. You don't see any stars. You just see like the black of space. And intellectually, it goes forever. It's the abyss. It's not like the science fiction movies where stars are flying by. So imagine going to Mars and you have windows and you see nothing but the abyss for 6 months. I mean, I think there's going to be an impact there. So I think we need a holodeck, something like that.
So Star Trek technology is truly the answer for our concerns in space. Dr. Mega?
No, I agree with your comments earlier, Abby. You kind of hit the nail on the head there. Autonomous systems. People are thinking about how AI can be used in that aspect as well. But there's a lot of challenges to solve there. No, I agree. One thing that struck me was the psychology aspect of things, as Tim was mentioning, and I believe the next workshop is psychology in space. So I'm interested in see what that workshop holds as well.
Yeah, you've stolen my plug there. I was planning to mention that if anyone is interested in continuing the conversation around psychology in space, please join us on March 27th from 1 to 3 p.m. over Zoom for a workshop focused specifically on that topic. Okay, now I would like to call out students and trainees and check if we have any students or trainees in the audience, either in person or virtually, who would like to ask a question. It's okay if you don't want to, but I want to create that opportunity. Okay, seeing no student or trainee hands being raised, we have time for, I would say, one more question. So if anyone has a burning question that they would like to hear answered by the panel, now is the chance. Yes.
So as we move into this new era, what are your thoughts on the most pressing needs to think about the ground facilities that are going to help fortify and advance science?
Yeah, so the question is around what does the ground infrastructure look like for the commercial space stations to facilitate the research on board? So probably lots of ways to skin that cat. Our approach has been to build the Vista Science Park here at the Ohio State University, partner with Mitsubishi for iPark, the Innovation Park in Dubendorf, Switzerland. But those are centers to make sure that the payload interfaces, the expertise, all those things can be co-located, but there will be a very distributed capability, just like, at Voyager, former NanoRacks has the bridge that can talk directly to International Space Station. So we want to be able to give that capacity to have distributed ability to communicate and even operate experiments on board. And, the technology has advanced to a place where we can do that both effectively and securely to make sure that we provide those opportunities.
Yeah, I think it's part of it is leveraging existing capabilities, as was alluded to, that have been utilized for ISS research, purposes. Like BioServe Space Technologies, who we've worked with for years now, have 30 years of experience, even going back to shuttle, in terms of supporting life sciences payloads. So, perhaps there's not a need to reinvent the wheel as much if we already have folks like various implementation partners who have just a tremendous amount of expertise in the area. So I think definitely leveraging their skill sets and their knowledge base to the full advantage.
Fantastic answer, and thank you so much for the thoughtful responses. I will mention that there was one more question in the chat that we haven't had a chance to get to from David Cohen, and I will just read it because I think it's interesting and then give a suggestion, which is thinking out of the box. Has anyone thought about reaching out to the Navy, submarine engineers, pilots, crew there, for example, for their input and ideas and experiences living in these similar environments? And David, great question. Please reach out to our friends at HPC, the Human Performance Collaborative, to talk further about that, because it is a great way to go about tackling some of these problems. With that, it is 12 o'clock on the dot, so I will go ahead and wrap up here and say a really genuine and heartfelt thank you to everyone here in the room today and on Zoom for joining us, for participating and engaging in these conversations, and really thinking with an open mind about what our futures in spaceflight looks. I hope from Voyager, from Starlab, from Cleveland Clinic, from Cedars-Sinai, from HPC and OSU, we're all grateful to have these conversations ongoing and are looking forward to participating with the research community in the future. So thank you all. And thank you so much to all three of our speakers for joining us today, for sharing your incredible experience and perspectives with us. We really appreciate it.
Thanks, Abby.
Thank you so much. Thank you.